A very good morning to all. On behalf of Interventional Cardiology Council of Kerala, I extend a warm welcome to all gathered here to the day 2 of Icck annual conference. We are starting the session. First session is on Medtronic Left Bundle Pacing Symposium. Requesting the chairpersons Dr. Abhilash SP, Dr. Anis T, Dr. Ravi Cherian to come forward and occupy the dais.
Welcome to you all for the second day of the Icck conference. It's my pleasure to be here to chair this session on left bundle pacing. We have two talks in the morning. Without wasting any more time, I will invite Dr. Shivaprasad sir to give his first talk on left bundle pacing and on how I do left bundle pacing.
My colleagues, this is a new area of pacing. This is a very important historic slide. You know what? Can you identify three persons on the left, on the upper part, and the three on the lower part? And do you remember this date? This was the date in which the first pacemaker was implanted by none other than Senning, who is standing in the middle here. And this is the person Larsen, and this is the engineer Elimquist who designed the pacemaker. And there's a very interesting story behind it, which I will tell you if time permits at the end. And this is the team simultaneously did it in America. Now, we all know that conventional RV pacing is the one which we do. RV apical pacing is the one which we do always. But we understand that chronic RV pacing, when the patient is dependent on a pacemaker, it causes a lot of detrimental effects. Mostly it reduces the survival, increases the heart failure rates, especially so if the LV function is on borderline or reduced, and it increases the chance of AF. I am apologetic for skipping through these slides, which shows the evidences that RV pacing is bad. Now, you know, RV pacing leads to a lot of structural abnormalities in the heart, leading to detrimental effects. I'm not going to the details, which is not the topic of choice today. What is the answer to this? Then we started thinking about, can we have alternate sites of pacing, which came RV outflow tract pacing, RV septal pacing. Then came the His bundle pacing with a novel idea that if you stimulate the His bundle, the impulse goes through the conduction pathway, you get a narrow complex. You will not cause dysynchrony to the heart. And this is going to be a very, very useful proposition. But in real life, what are the problems with His bundle pacing? Inability to record a His bundle signal in about 10% of the cases, correct the conduction disturbances, unacceptably higher threshold in 30% of the cases, undersensing of the R wave, but at the same time oversensing of the wave, which is not very ideal, unstable position, and future rising threshold. You need a steep learning curve. There is a chance of dislodgement. No tools yet available for a large RA. So this is technically more challenging than putting a lead in the RV apex. Then came the concept of left bundle branch pacing. You can see the structure of the left bundle. You can see the bundle of His here, branching His bundle, right bundle and left bundle. This picture itself gives you an idea that you have a large area, curtain-like area of the left bundle, which is available on the right side of the heart to place a pacemaker lead, and you can screw in the lead to this large area. You have a freedom of going through this structure, and you can pace the ventricle, and you can reduce the wide and QRS. And this is what you see, which is cartoonized here or superimposed on the specimen. You see the AV nodal area or His bundle area. This is the area where you are free to put the His bundle electrode. You know, see this very narrow area. And here you have the broad sheet of left bundle where you can place the electrode away from around 10 to 15 millimeters away from the His bundle. And this is where exactly in practice we place the His bundle electrode. And if you also take the idea that left bundle branch block exists in many of the patients, you can see that more than 50% of the cases it occurs in the proximal, in the distal part of the His bundle or proximal part of the left bundle. So if you place the electrode little lower down, you can circumvent the left bundle branch block effect in the patient, and you can narrow the QRS complex. here, what are the advantages? Threshold appears to be more stable, more effective in infranodal AV block, less risk of developing distal conduction block, wider target area, apparently more technically less challenging than his bundle, and effective QRS narrowing. With this idea in 2017, Huang from China and Ilangoban from America decided to pace the left ventricle to the left bundle branch, and this is the birth of left bundle branch area pacing. And this slide actually summarizes my talk. You have to pre-procedurally assess the IVS IVS thickness by echo. Then you can access through the femoral vein or jugular vein to have an RV pacing and his bundle recording. This is not mandatory. You can get away with an atrial electrode which you put first into the RV in case you have a patient with left bundle branch block and you're going to pace it. You bump onto the right bundle and can cause complete heart block. But circumvent that, you can put the atrial electrode first into the RV. In case needed, you can use that. You can also use the same his bundle, the left bundle pacing electrode 3830 to identify where the his is. Once you mark the his point, you remember it, or imagine that you on the fluoroscope you make some landmarks where the his bundle is, and from there you draw a line to the RV apex, an imaginary line, and around 10 to 15 millimeters down the his bundle is the location of the left bundle, and where you identify the left bundle, identify the electrophysiological characteristics, and screw in the electrode, and then that summarizes the talk of today. Actually, this is what's in nutshell the procedure is. Here, you go verify the position. You are using a sheath. After the puncture, I'm going to deal with the punctures and all this later. This is the lead which is taken in RAO 10 with 45 degree counterclockwise rotation of the lead. It will get into the RV. Now you from this is probably the position of his, and then this is the area in which you are going to try. And this is the lead which is placed, about to be placed. What you do after reaching that area, you pace map the RV side of the septum at the desired site. What you look for is, in the beginning, you will get a W pattern in the intracardiac electrocardiogram with the hump in the initial part to the proximal part of the W. Then as you go deeper and deeper, this hump will go towards the lateral part of the W, and then you will get the left bundle branch. Towards the left bundle branch, you get a QR pattern or an RS R- pattern which you will key. Another important phenomenon which you look is AVR, AVL discordance, which I will show in ECG, or a lead 2 more than lead 3. Rotate once or twice, you verify, then screw 4 or 5 turns more, you get into the left bundle area. When you do it, you have to identify that you are reaching the left bundle area based on the ECG change. In V1 change from W pattern to QR pattern, which I will show through diagrams later on, a narrow QRS, and the most important left ventricular activation time less than 80 milliseconds. You can also identify left bundle branch potential if you are very keen on this, or retrograde his deflection, which may be available in some of the cases. An acceptable threshold is 50 to 500 to 550 impedance, and low cap threshold less than 1 volt is an acceptable parameter. Now, this is the way in which you make an incision here, either incision parallel to the inferior border of the clavicle, or can be an incision like this. And you have 2 accesses, and then this is the sheath 315, which has got 2 curves, which is designed to be kept to identify the his bundle area. The same gadgets are used for left bundle pacing, and it is straightened using a guide wire, and this is what is being planned here, what is implanted here. This is the guide sheath, and this is the lead which is abutting the septum. You can see this is the his bundle electrode 15 millimeters down. This is the line in which I am talking about, from the his bundle to the RV apex, and this is the line in which you arbitrarily try for a left bundle branch side pacing, and this is actually the cartoon showing the left bundle branch axis. And
I
this is
cannot
what
emphasize
you
enough
should be very,
the
very careful.
two-handed
You should have
technique for
dry
screwing the
glove.
lead.
It should not be a wet glove. what I do is I'll
Properly
keep two
using the
gloves.
two-handed
The first one
technique,
I
you
remove
need
and
clean
keep the
gloves. And this
inner one
sounds like a
ready, which is
ridiculous
dry,
thing to
and I
say. And when
keep the lid.
Satosh first
I'll
told
not.
this to me, I
You
thought,
should not
man,
rotate
you're
at
an
the
anal
distal tip
guy,
of the
like,
lead.
you know, who
You should
has
go to
clean
the
gloves.
near the hub
But
of the
he
sheath,
was
catch it
totally
between two
correct.
fingers
Either
and
wash your
rotate it. If you
hands with
see
your
it here,
gloves or just get
rapid
a new pair
rotations, you
of
can see
gloves,
that
brand
you are
spanking
having,
clean fingers technique, and watch how he is
see,
screwing this
this
lead. It is a
synchronous movement. This will make
two-handed
the
technique.
lead
Both
penetrate the area
fingers
where you
are
intend to
very
go, and
close to
you
where
get a
that
good
lead
penetration to the
enters
septum in
into.
the left bundle branch area. This is what we have been doing. The other one was taken from the internet, and this is what we do with two hands. My assistant, Dr. Praveen, was holding the sheath in 45-degree angle, and I'm doing a rapid turning. And what you should, this is what you get, some penetration into the, what this is what you should look for. In V1 there is a W pattern in the beginning, and towards the end you can see there is a QR pattern. And when you go from superficial to deep into the septum, initially the W pattern, the notch is here, now the notch is becoming more distal, and now you get a QR pattern. This is exact final morphology. This is where you have reached the, then you also watch the resistance. If there is a sudden drop in the impedance, that means that you have perforated the lead to the LV. No need to worry. You can pull back, re-enter through another side. And this is another thing which I said, that is AVR, AVL discordance. You can see AVR is negative, AVL is positive. These are color coded to just to identify easily in the screen. You can also see that lead 2 is more than lead 3, and also you can see the V1 showing a QR pattern. So this is what I talked about, left ventricular activation time. If you are directly on the left bundle, you will get a left ventricular activation which is less than 80 milliseconds. Here you see in this patient, it is left ventricular activation time is 70 milliseconds, and that itself shows that you're directly stimulating the left ventricle. But you test this in two different voltages. You can look at it 5 voltage and 1 voltage. At 5 voltage, the current is too much. It is directly stimulating the left bundle. But in a lower voltage, you see the myocardium gets stimulated. You are not exactly in the left bundle area. There is some myocardial stimulation. That is why the left ventricular activation time is more. Now, if you turn little more, you reach the bundle, and can see that both at high and low voltage, the activation time remains the same. And that is a very acceptable method. Now, I'm sorry, this is a very narrow QRS complex which we achieved in this patient, 78-year-old lady. And these are other parameters, left bundle branch potential, which we don't usually look for, or a retrograde His potential also we don't look for. After placing the screw in electrode, it is very important. You should be very careful while removing the sheath. This is actually the same thing which you do for CRT. You be careful. You can see that my right hand is very steady, and with the left hand I pull the sheath out, slitting it, and at the same time my assistant is holding the lead once it is released, so that lead dislodgement at this point will not happen. So we have now suggestive data that this is going to improve the outcome, improves the lift ejection fraction, dimensions, exercise tolerance, prevention of deterioration of LV function. The downside, we have only very short-term data. We don't know about what happens long term to this lead. Micro and macro dislodgement, lead perforation to LV, cardiac tamponade, technically more challenging than RV pacing. Will it replace biventricular pacing? At present, it is class 2B. We will talk about this by Dr. Narayan is going to give you a lot of data on this. And these are the youngest in Tudor who had a pacemaker. And this is what the interesting story behind the first pacemaker. Elsie Mary was Larson's wife. He had a problem of recurrent syncope, and this energetic, beautiful woman entered the lab of Senning on 6 October while they were doing something with the pacemakers, yet not ready to be implanted in humans. But she said, I want one, and so you make one for my husband. So on 8th evening, as we do when you are doing a very first case, we do not inform anyone just to make sure that we are doing a safe procedure. They did in secrecy in the lab, implanted the pacemaker. It worked for 8 hours. But due to some technical challenges, it worked only for 8 hours. Next day morning, they replaced with another, which worked for a week. And this was the birth of pacemakers. And this person outlived the surgeon and the engineer, and he died due to a disease. It is unrelated to conduction system, which was due to malignancy. And he had 5 reimplantations, and he survived a conduction system block. Thank you very much.
Thank you, sir, for the excellent presentation. Just one question, like when you are selecting patients now, because left bundle area pacing may replace RV pacing as the preferred method of pacing in even in AV blocks without structural heart disease or normal LV function. Is there some way you can advise the newcomers in the field, like which patient you should not do left bundle pacing, which patient you should do left bundle more than RV apical or RV septal?
One thing which you can have, while if you select the patient and then you try to screw in, if there is a fibrotic area in that area, it will be very difficult for you to get in this lead in. And sometimes you see that it backlashes and it do not turn as you wish in a case. Then I had to back out in one case where I did an RV septal pacing. We have to go lower down. But even such situations, now the people say that you can do a little more lower down. You get a narrow QRS complex. You're not exactly what you get in LVAT. Now people is accepting below 100. So you can try for another position. And exactly a contraindication as such, no, we don't have. We can try, but in biventricular pacing, if you fail to achieve the optimal pacing thresholds and you see you're troubled with phrenic nerve stimulation, you can have left bundle pacing as an alternative to improve their LV function. That's what I felt. But there are situations in which you are unlikely to meet with the criteria of left bundle pacing. There, you may have to resort to the same lead can be used for septal pacing. You can go down and do it. But the only thing is, this lead is lumenless. So you cannot put in a sheath and you do it in a still it and take it down. You have to manually take it down, but you may have to straighten the sheath which you use. You can straighten the sheath using amplats or wire and take it down to the septum and place it in the septum in case you find any difficulty with the left bundle pacing.
As sir suggested, one difficult subset is the scarring in the septum. The another subset may be, sir, LVH, say septal thickness more than 14 millimeter. The lead may not reach the left side of the septum when there is significant LVH.
And we have only very minimal data about the efficacy of this. Unless you get the optimal parameters, I don't know whether all the alternatives are going to be as much helpful as what it's intended out of left bundle branch pacing.
One advantage of the left bundle pacing compared to his bundle is actually we do not require an EP lab. We can do in any lab. We need only 3 or 4 leads. V1 for looking for the narrowing of the QRS and change of pattern to QR. That is enough. And V5, if it is there, LV activation time. Lead 1, lead 2, lead 3. 2 and 3 will say we are capturing the mid septum or not. Lead 1 and lead 2 will say which fascicle is being captured. So even with a just V1, we can do a left bundle. That's the beauty of left bundle. One important thing is, sir, like the output, we need to test at 2.5 to 3.5 to know what is the real QRS duration. Even if we get a good left bundle at 1 volt, but if it is broad at 2.5 to 3.5, it may not matter to the patient because we are not going to keep the output at 1 volt. So 2.5 to 3.5, what is the real QRS? That will make the difference.
Yeah. One thing that Dr. Anish asked, is there any contact? Is there a distal left bundle branch block, which occurs in about 10 to 20, 30% of the cases? I don't know whether a proximal left bundle pacing is going to alter this whole phenomena. There probably a combination of left bundle pacing with a biventricular pacing may help, especially sarcoidosis or cystic infiltrated disease where progressive conduction system disturbance can happen. This happens in a small number, but it can. There, it may not be of much benefit.
Any questions from the audience?
This patient cannot afford to have asystole and things like that. You need a reliable pacing for bradycardia indication here. So in that situation, will you do this?
You added an adjective, reliable. We have only very short-term data about this left bundle pacing. If you can achieve very ideal parameters and you're happy with it, you can. But otherwise, here the problem is only a bradycardia, not due to ejection fraction low or patient requires a support for the heart rate. I think a septal pacing is going to be equally effective, because here we don't have data regarding a good LV function patient and left bundle pacing. Only thing is, it will give you a surrogate marker that you are created a narrow QRS complex. That is all. But at the same time, you are uncertain about the long-term effects of long-term stability of this lead. Till now, we know that it is stable, but there are micro and macro dislodgements. But as of now, it is a relatively safe alternative procedure. But if the patient has got a low ejection fraction, definitely the things are different. You should try for something which will preserve the LV function.
Just wanted to add, sir. That was the question. Like, I would generally not do left bundle pacing. Suppose in an elderly patient who come with torsates, with brady-induced torsates, it's very important to maintain the reliability of pacing. But unlike a patient with narrow QRS escape with a heart rate of 60 or 55 with complete heart block, who is otherwise asymptomatic, you may prefer left bundle. But in a patient, elderly lady with torsates, brady-induced and all, don't try this at the beginning stages itself. That's what I think
I think we'll close this section and go to the next session.
Thank you so much, sir. So before moving on to the next session, may I request all the chairpersons and speakers to strictly take an out on the allotted time for the presentation and speech. Thank you all. So now we'll have the next session on interventions during ACS, requesting the chairpersons, Dr. S.S. Binu, Dr. Sibu Matthew, Dr. K.U. Natarajan, and Dr. Suresh Ki to come forward to the dais and occupy the seats, please.
And please note, one of these cases will be discussed in detail by Dr. Natarajan at the end of the session. And that case is an interesting case of acute MI intervention.
Good morning, everybody. Pitchforked into the battlefront so early in the morning. Thanks very much, Scientific Committee, Dr. Ashish and Dr. Abhilash, for the privilege. Let's start with the first case by Dr. Santosh from PRS Hospital.
Thank you, sir. First of all, let me thank Dr. Pratap, Dr. Abhilash, and Dr. Ashish for giving us such a beautiful meeting. I'll be presenting a case of acute stent thrombosis. This was a 56-year-old gentleman, a big businessman in Trivandrum, and brother to one of our senior consultants. He came to our OPD around 1 o'clock in the afternoon, walking, diabetic, had chest pain for the past 2 days, top was positive. We diagnosed an anterior wall honesty elevation based on ECG. And the consultant was insisting that we do an angio at the same time. So that was the right coronary issue. If you want anything repeated, please tell me. He had a ostial LAD lesion and ostial ramus lesion. So
Dr. Santosh, can you show that last angio, please? Yeah, that one. Okay.
So we wired both the LAD and ramus, dilated with balloons. And stented the LAD from the ostium. Fair results. We proceeded with the ramus stenting. We don't have imaging in our hospital, so we didn't do imaging at that time. And we thought that the results were satisfactory and the patient was shifted to the ICU. After 1 hour, patient developed severe chest pain, significant ST elevation in precordial leads, and a check angiogram through femoral was done. Both the stents were occluded and the distal left main was occluded. So we wired both vessels, repeated thrombus aspirations and balloon dilatations were done. We thought that okay, but there was some little narrowing at the distal left main area. After repeated things, again the flow was not good. Finally, we got this result, but we thought that there is probably an ostial dissection at the LAD. We stented from left main to LAD. Then the whole picture changed. The thrombus disappeared, and we did a recrossing and kissing balloon dilatation. And this was the final result.
Santosh, you have finished?
Yeah.
Nice presentation, nice result at the end. Do you think that the osteal LAD dissection was the cause for the acute stent thrombosis?
Probably, sir. There are two things. Yeah. Two questions actually. One, whether we should have left the ramus alone in the first place. If you see the post-stenting angios, I think the ostial LAD stent was a little affected by the ramus stenting. And probably that would have produced the malapposition of the stent in the LAD and thrombus formation. So probably we should have left the ramus alone in the first part. Or whether we should have gone ahead and stented from LAD to left main to LAD in the first place. So the two questions we were asking ourselves in the post discussion.
So when you did the ramus, you pulled back and from the ostium and you stented.
Yeah.
So probably there could have been a miss of the ostium of ramus, or probably there can be deformity of the left LAD. That is what you discuss later.
Yeah.
Okay. So would have been better to stent from LM to LAD and treat it as a bifurcation.
So I think from ostial LAD lesion, it would be either you send the patient for CABG, or it would be better if you stent from left main to the LAD rather than stenting at the ostium. So most of the time what will happen is either you will miss a small part of the lesion, or because of the probably a mismatch of the diseased ostium, you might end up with a micro dissection at the ostium of the LAD, which might later on lead on to a thrombus formation. This patient had on ECG severe ST elevation, hypotension, severe pain. Patient was rolling about in the bed, and I think it could all have been avoided if we stented from left main to LAD, recrossed and stented the ramus if needed. Yeah.
No, I fully agree with what Dr. Santosh finally mentioned. Whenever there is osteal disease in fact, there is no osteal disease of the circumflex also in this case, though it was not as severe as the ostium of the LAD. And your last, that LAO caudal shot also clearly showed that there is some suspicious distal left main. Yeah. So when there is no imaging, we have to critically see the distal left main before venturing into a bang ostial stenting like you did. And probably you should have a lower threshold to stent from the left main to LAD in this case. That is the lesson that we learned. Yeah. You also must have regretted not having done that. Nice case. Yeah.
Thank you.
By Dr. Krishna Kumar, a double trouble.
Good morning, all. I'm going to present a case from General Hospital, Thrissur. In fact, it is not an acute coronary syndrome, but turned out to be an ACS eventually. The story of a 47-year-old male presented to our OPD with effort angina function class 2 for the last 4 months. Echo showed good LV function. TMT came to be positive at 7 months. He was taken up for elective coronary angiogram. Then the left coronary artery showed a discrete 90% lesion in the mid LAD. And the right coronary artery also showed a discrete 90% lesion distally. So our plan was angioplasty to LAD and RCA. So we first went ahead with LAD. The lesion was wired with run-through NS, pre-dilated with a 2x12 semi-compliant balloon, and proximal to mid-LAD was stented with 3x24 drug-eluting stent, and was post-dilated with 3x12 non-compliant balloon, and we got a reasonably good result in LAD. At this point of time, the patient developed severe spasm in the radial artery. Then the access was changed to right femoral artery. Then RCA was hooked with 6 French JR 3.5 guiding catheter. The lesion wired with run-through NS, pre-dilated with 2x12 semi-compliant balloon. And distal RC was stented with 2.75x29 drug-eluting stent and was post-dilated with 2.75x10 non-compliant balloon. Finally, we got a good result in RCA as well. And the patient was about to shift to the post-cath ICU. But at this point of time, he developed severe chest pain. ECG monitor was showing significant ST depression in the inferior leads, and he also developed hypotension. So we thought there is some issue with the stent. So the left coronary artery was hooked with 6 French EBU guiding catheter, and we did a check angiogram, and it showed total occlusion of LAD, but we couldn't save the image in that rush. We immediately wired LAD, and there was TIMI2 flow with wiring itself and significant haziness in the proximal part of the LAD stent, suggestive of acute stent thrombosis. Then serial dilatation with 2.75x12 non-compliant balloon, and thrombus aspiration was done. Intracoronary thyrofeban 10 ml was given. Finally, there was TIMI3 flow in LAD. The ACT check was done at that point of time. It was only 200. The patient's body weight was 80 kg. We already given 8,000 units of heparin. So an extra dose of 2,000 heparin was given. Then we found that there is proximal part of the LAD stent, there is some haziness which is not getting cleared with thrombus aspiration or balloon dilatation. Then we reviewed back to the previous images. We found that the post-stenting image of the LAD, there was some suspicion of edge dissection proximally, but we couldn't confirm it because we were not having any imaging at that point of time. So we thought we should fix that dissection with another stent. So 3x13 drug-eluting stent was placed across the haziness, overlapping to the previous stent, and was deployed. So finally, we got a decent result in LAD. We thought everything is over now, the patient is stable. Actually, his pain got subsided, but the ECG monitor now started showing ST elevation in the inferior leads. So we thought we should check the right coronary as well. Then the right coronary was hooked with 6 French JR guiding catheter. It was showing total occlusion distally. So it was acute stent thrombosis of right coronary as well. So we wired with run-through NS. ACT check was done again. It was only 210. So already the patient was given 10,000 units of heparin. So an additional 2,000 units, so making a total of 12,000 units of heparin was given to the patient. Then POBA to the distal RC was done with 2.75x12 non-compliant balloon. Finally, we could achieve a good result in RCA, and the patient was discharged on day 3. This happened actually 6 months back. Now the patient is still under follow-up, and he is doing good. So stent thrombosis, we know there are various factors, patient factors like PCA for acute coronary syndrome, premature cessation of dual antiplatelet, clopidogrel non-responsiveness, but seldom occurs in the era of newer antiplatelets, lower ejection fraction, current smoking, diabetes, malignancy, procedural factors like stent under-expansion, residual edge dissection, which happened in our case, lesion factors like LMC or proximal LAD lesion, bifurcation lesion, severely calcified lesion, then saphenous vein graft lesion, stent factors like overlapping stent, long length of the stent, stent fracture, hypersensitivity to the drug-eluting stent. So the take-home message, on-table acute stent thrombosis is a serious complication during multi-vessel PCA. Imaging like IVUS or OCT have important role in multi-vessel PCA, probably for the detection of misdissection or malapposition. Care is needed from the operators for early detection of such complication because it may lead to mortality. Thank you.
Thank you, Krishnamar, for the nice presentation.
Thank
So, in the first stent thrombosis, the LAD, after what time, how much time it happened?
Actually, it was just before shifting the patient back to the
And
post-cath
second inferior wall on the table itself?
On table itself. Both occurred on table.
The first, the patient had significant hypertension?
Yes, yes, sir. Initially, the systolic BP was 140/80. Now, during the event, systolic went
and
to
which
80.
antiplatelet was the patient on?
Patient was loaded with ticagrelor.
So what do you think that the LAD definitely there was a dissection, that was the reason. But what could be the reason for RCA?
Maybe the heparin, some issue with the heparin batch at that point of time, and the ACT was low throughout the procedure. So for LAD, the edge dissection might have contributed, and RCA, subtherapeutic heparin.
And contributed by probably hypertension also.
Yes, sir.
Maybe.
I didn't want to ask anything. I was also thinking the same thing. Number one, your presentation underscores the importance of imaging techniques.
Yes.
To pick up what is really happening. Unfortunately, you didn't have that. The other thing I was thinking is about the quality of the heparin.
Yes.
Because in spite of loading with so much of heparin, the ACT was always hovering around the value of 200.
Yes, sir. And after this case, we
really
changed the
know
batch.
What happened in the right coronary artery?
Okay, thank you.
After the second stent in the LAD, it was almost very close to the ostium.
Yes.
Maybe. And if you see carefully, the ostium was not normal. So whenever you come dangerously close to the ostium, it is better to cover the ostium also. If there is angiographically any suspicion of osteal disease, what I have learned from bad mistakes in the past. That was one observation.
Thank you.
Nice case. Yeah.
Thank you, sir.
Just one question. Was it an ad hoc PCA? Was it an ad hoc? Was the patient on antiplatelets, or it was an ad hoc PCA? He was loaded on antiplatelets on the table?
Actually, he was loaded with aspirin the previous day. Then on table, he was loaded with ticagrelor 180 milligram.
Okay. On table, he was loaded with.
Yeah, ticagrelor was loaded on table.
What should be the strategy for an ad hoc PCA on antiplatelets? Just for your, the patient is not on antiplatelets, came for an elective angiogram showing it. This is on table going for an angioplasty. What should be the antiplatelet strategy? Should be given anti-GP2B or just give a ticagrelor bolus and loading dose and continue with the...
You're talking about presentation as acute coronary
No,
syndrome.
I'm not saying. Came for an elective angioplasty, just like a angina class 2, came for an elective angiogram showing a lesion and taking for an ad hoc PCI.
Who has never been on antiplatelets.
Never been on antiplatelets. Most of us will be just taking the patients for an ad hoc PCI. Like, what should be the antiplatelet? Should be given and GP2B or just load with
no, when somebody's presentation was not acute coronary syndrome, GP2 antagonist is not required. It is an overkill. You mean to say somebody never on antiplatelets, just you did an angiogram, found a critical disease, and you are desiring to do an angioplasty. You should do the way you do for an acute coronary syndrome, loading dose. Preferably, you can wait for some time. You can do ad hoc.
Non-STEMI, even the ESC guideline says, you should be loading on table, not before. So I don't think GB2B3 should be given. But even non-STEMI, when you're giving just on table for elective, it should be fine.
Instantaneously we can do, isn't it? You can give the antiplatelets and proceed with the angioplasty, isn't it?
Sir, Andy, and if you end up with having multiple stents or a left main bifurcation, something like that, probably cangrelor would be.
Thank you, Dr. Krishna. So we move to the third presentation, a rare etiology for inferior wall myocardial infarction, tackled through a multi-pronged approach. Dr. Sandeep Mohan. Very catchy title.
Thank you, sir. Good morning, respected teachers, dear friends and colleagues and seniors. First of all, let me thank the organizers for giving me the opportunity to present today. So this is actually more of a rare etiology for an acute coronary syndrome rather than an exotic interventional procedure. we had the 64-year-old female with diabetes mellitus. She had exertional dyspnea since the previous year. There was one episode of severe chest pain and giddiness while she was climbing the stairs quickly, and she was a VIP patient, aunt of a doctor in our department itself. So by protocol, we asked her to do a TMT. At the TMT room, she collapsed and went into cardiogenic shock. The ECG showed an ST elevation 2-3 AVF, and it was a florid inferior volume. We took her to the cath lab immediately. To our surprise, there were no coronary artery disease as such. It was a coronary to PA fistula from the left coronary artery, and it was uniquely arising from the ostium of the LAD, just behind the ostium of the LAD, probably at the LMCA bifurcation, diametrically opposite to the left circumflex artery. You can see a large tortuous fistula, which is draining into the PA. Interestingly, there was also another PA fistula that was arising from the right coronary artery from the proximal segment, and multiple small tracts also from the aorta directly to the PA. So the further workup was by a CT coronary angiogram to confirm the extent of the findings and to plan the procedure. CVT's opinion was taken, but usually in proximal fistulas, they usually don't touch it. And we decided for transcatheter intervention. The procedure was standard. We should always protect the LAD when there is a proximal left coronary artery fistula. We took a run-through wire deep into the fistulous tract and tried to put down a direction microcatheter. But it was very difficult to track to the desired segment, and each time we pushed, the entire system was coming back. So we changed to a more talkable wire from Abbott, and this time we took up a pro-grade microcatheter, and with some difficulty, we could get to the desired distal segment. And we first deployed the a 3x3 Hilal microcoil, and later we deployed a second microcoil. We chose a longer one, 4x14 Nestor. And with that, we could achieve complete obliteration of the fistulous tract, and the flow to the PA was significantly reduced. And in the same sitting, we went to the right coronary artery, and this we decided to go ahead and close with a covered stent. It was a 4x16 graft master. However, the first stent could not completely occlude the leak, and then we had to use a second covered stent. And with that, we could achieve complete obliteration of the fistula. You can also note that there are multiple small fistulous tracts from the aorta. At this point, we thought we will not intervene right now, as most of the shunt would have been reduced with our intervention. We did a follow-up at 6 months. The TMT was absolutely normal. The patient was also fine. We also did a coronary angiogram, CT angiogram at 1 year, and we can see that there is a complete obliteration of the fistulous tract from the LAD, LCA to PA, and also the covered stent in the RCA was also patent. The coronary AV fistulas are extremely rare findings, usually noted in 0.2% of cardiac catheterization. Bilateral coronary to PA fistulas are the most rarest of them and account for around 5% of all. ST elevation MI is very rare in coronary PA fistulas, and usually the cases reported are always have a simultaneous coronary artery disease in them. And it is important to treat all the symptomatic fistulas. Transcatheter versus surgery depends on the position, the tortuosity, ability to reach the distal portion. The distalmost segment should be narrow, and there should be no other indication for CABG. Recanalization may occur in these patients, and they should be followed up with imaging. And multiple strategies may be used depending on the anatomy and the individual vessel characteristics. Thank you.
Most of what you said is perfectly right. Only thing, a patient with such fistula presenting as cardiogenic shock after a treadmill test was a little difficult to comprehend. Any thoughts on that?
Sir, this patient had a definite chest pain while she was climbing the stairs at home also. And the next day she came for the TMT. Probably there was a steel phenomenon into the left circumflex, from the left circumflex into the... We have seen such PA fistulas during pneumonia causing anstemy, ACS, etc. So there must have been a steel phenomenon that has happened. It is a very rare presentation. I cannot explain how she had ST elevation 2-3 ABF just because of the...
Usually cardiogenic shock happens when there is an occlusion of a vessel, you take to the cath lab, you find no flow in one of the coronary arteries. This is expected to cause effort-related dyspnea or angina, but unlikely to cause. And you didn't show the TMT tracings. You only said patient developed cardiogenic shock at the end of TMT.
There was ST elevation. I forgot to include the TMT tracing.
Anyway, exotic case.
Thank you, sir. I think it must be the LCX because the tract is diametrically opposite to the left circumflex, and that was the bigger territory.
Any specific reason why you chose a covered stent to tackle the RCA part?
Sir, it was very anatomically very appropriate for a covered stent rather than a coil because there was no other branches arising. So actually I had to use 2 covered stents. Probably the first stent slipped a bit forward.
So suppose he could coil it, the RCA, then a coiling would have not put a stent in the RCA with a subsequent, there are 2 covered stents, subsequent chance of restenosis or other problems.
Yes, sir.
So would you have preferred a coil if you can do it?
Yes, sir. You're right.
Thank you so much for a very
Thanks.
exotic case and very nice case. Thank you.
I think let's get on with it. Next case is by Dr. Srinivas from PSM Hospital, Mavelikara, a midnight adventure.
Respected teachers and my dear colleagues, I thank you for organizers for giving me an opportunity to present in this session. The topic is a midnight adventure. As the name suggests, the case came at around 11 p.m. at midnight. He was a 49-year-old male. He was a diabetic and hypertensive and smoker and dyslipidemic, and he complaining of acute onset to central chest pain around 2 hours duration. And on admission, he had borderline hemodynamics, and ECG showed ST elevation, lead 1 AVL, V1, V6, and non-sustained VT in ECG. And echo was showing a severe hypokinesia of septum, interval, and severe LV dysfunction. And he was started on with inotropes, and we got a reasonable radial pulse. So we taken the patient for a primary PTCA. As the patient condition was poor, so we initially tried with the guide itself. We engaged the right radial artery with an EBU 3.5 gating catheter. You can see the LMCA was 90% occlusion lesion followed by an LAD total occlusion. So RCA which was taken after this case was a dominant vessel which had minor disease. We were initially considered emergency bypass in this patient, but as the time was not right and patient condition was not satisfactory and CABG was not available with us, so we discussed everything with the bystanders and they were concerned for the high risk PCA. The problems anticipated in this case was difficulty in wiring, difficulty in dilating the lesion because there was a calcified nodule in the distal left main, and stent deformations. All these complications we were expected, and we initially started wiring was not difficult. It was wired with a run through NS and pre-dilated with a 2.5 and 3 mm balloon. And we initially stented the mid LAD with a 3 into 33 mm science. And we got a reasonably good vessel in flow in mid LAD, and we stented the LM to LAD with a 3.5 into 38 mm science, and post-dilated with a 3.5 into 10 mm balloon, and proximal optimization was done of LMCA with 4.5 into 12 mm balloon at 20 atmospheres. At this point, we complications which were expected was one side branch occlusion, slow flow, and borderline hemodynamics, and there could be a stuck in the port balloon can stuck in gate in this after the port balloon removal. So we did this port lastly so that if the balloon is stuck, we can remove it. Everything was an en masse procedure. So we did it last. And we thought everything was finished, but the last shot before wire removal showed a suspected dissection in the distal to the distal stent. So that also we covered with a 3 into 18 mm stent. We got the final good picture. These were the hardwares used: right radial, pre-dilated, stented 33 and 3.5 into 38, and post-dilated, and proximal optimization done. The take-home message is primary LMC interventions can be done radial with through 6 French guiding catheter, but you have to consider the clinical status. The difficulties are could be long stent tracking, slow flow, side branch occlusion, stent deformation, catheter dissection, for which careful catheter manipulations are needed. There could be stuck of port balloon in the gate because it's a 6 French guide and 4.5 balloon which could stuck, but you prefer to use an end guide and end port balloon, and preferably it should do it last. If it has to be removed, it can remove. If it's stuck, it can remove it as en masse. And each give a breathing time for coronaries before stenting, so that coronary flow has some time to establish, so that the next stent to be placed. And give the treatment of slow flow to be given prior to stenting and after stenting, that can reduce the incidence of slow flow. And always a good angio before wire removal is better, always better than a check angio for stent thrombosis later. Thank you.
Thank you for the nice presentation. Two questions. One, why did you anticipate in a 6 French, do you always anticipate the balloon to be stuck in the guide?
Sir, it's a 6 French guide, so 4.5 balloon. If we use an ox balloon, sometimes it can stuck. So I used an N balloon, and it did it last it last. The port of LMC which was done last. So if it is stuck, it can remove as an N mass.
Okay, port is after deploying you did the port.
Yeah, port was done. It was done after the post alteration of distal stents.
Okay, that after the dot.
After.
Okay. One more thing.
No, sir. The imaging was not available. Angiographically, no, sir. Angiographically looks to be a calcified nodule. Imaging was not available.
So there was one mention about the pre-treatment for a slow flow. What do you mean by that?
Sir, there is a chance of slow flow in this case, probably. So before Nicoran, SNP on all give Nicoran, then NTG all can be given before the stent deployment.
So is it found to be beneficial?
No, I don't know, but
pre-treatment is.
It will be given after post the stenting.
Okay.
That is sure. But
Thank you, Dr. Srinivas. Good case, nice way of doing it.
The next case is by Dr. Muhammad Mustafa, Enstemy tortuous vessel.
Good morning, teachers and my seniors and colleagues. I'm going to present a case of Enstemy in a tortuous RCA. The patient was a 79-year-old male, presented to ED with chest pain of 2 hours. He was a diabetic and hypertensive, and ECG was showing AF rhythm, ST depression in V4, V6. Echo was showing RWMA to RCA territory, and there was moderate MR. After initial management, and decided to go for coronary angiogram. So diagnostic angiogram. This diagnostic angiogram showing the RCA was very tortuous. The origin seems to be normal, but after that it is taking a upward course and it is suddenly taking 180-degree turn, U-turn, then again going back, then coming back to AV groove. So this morphology looks like a double Shepherd's crooks. We proceeded for PCI, right radial approach, 6 front 3.5 guiding catheter was used, JR. There was no proper gate support. Fielder FC wire could not take the tortuosities. There was no pushability and the gate is getting kicked out. So next plan was wire was changed to fielder XT wire and took the tortuosity and crossed the distillation and wire parked in PLV. 2.58 mm NC truck balloon could not track and the gate is getting kicked back again. So fielder FC wire used as a buddy wire and passed along the XT wire and parked in PDA, and we could predilate the lesion. After that, stenting was again problem. 2.75 12 could not take the tortuosity and pass through the XT with body wire support. Plan was changed again. So we decided to use the guide extension catheter. Guideliner was used up to the proximal RCA by using both the wires. And so that RCA got straightened and the stent could pass through the lesion and deployed at 14 am and post dilated with 3.8 NC balloon and 28 am. So this was that scene image showing body wire with gate extension and stenting. And final result showing good telemetry flow. Take home message, tortuous vessels will make your procedure difficult due to increased friction on your wire and equipment. To improve the torqueability, we can use the hydrophilic wires FC XT Whisper Pilot series instead of Workhorse wires. And we can use micro catheters. Otherwise, we can go with other guides like AL1. Here we completed the procedure with the JR only. And other guides like XB and all we can use. Take the advantage of vessel straightening. It will improve the stent delivery, but work quickly to avoid the ischemia. Post procedure, the result was good. Thank you.
Nice case. So the tortuosity when the wire is difficult. What is your workhorse wire? You start with FC.
Because by seeing that tortuosity, I thought that B&W wires will not go. So initially only I tried with FC only. But that was not able to track, so I used XT. Then after crossing the XT, balloon was not going. So I put FC as a body wire. Then I could pass.
So the catheter backup might have been a problem. Yes. Could have used a better backup catheter also.
Yes.
Nice.
There was a nice demonstration of using a guide extension catheter in case of difficult stent tracking. Yes. Nicely done. Thank you.
Thank you, sir.
This is postponed. This is the last presentation. No? That's what you wanted. Ashish? Pardon? Plus means what is coming up? So next to be called is? Okay. Dr. Bino Benjamin. He will present a case of LM bifurcation stenting during primary PCI.
Good morning, respected teachers, senior colleagues and friends. This is the story of a 47-year-old lady who had acute STEMI anterior wall. She was a diabetic. She had ongoing chest pain. Blood pressure was 110/80, heart rate 88, and echo showed RWMA in the anterior wall with an ejection fraction of around 30%. And this was the angiogram. Actually, this patient, it was approached through radial, and EBU 3.5 6 French was used to engage the left main. You can see there is a hazy lesion in the proximal ostial LAD. And after a small S1, LAD is totally occluded. RCA is non-dominant. It's a large 3.5 mm LCX, which is dominant. And as you can see from the ostium, LMCA has got some tubular disease. So the anatomy is, it's a short, LMCA is short vessel with a tubular disease from the ostium. Relatively small 2.5 mm left anterior descending with an ostial hazy 70% stenosis, which is totally occluded after a small S1. And circ is relatively, there was no significant disease, 3.5 mm dominant vessel. So how to approach this? There was a limitation we had. Imaging could not be done. It was a STEMI with ongoing chest pain. Patient had financial constraints and it was an overtime. So here, as LCX was not having any significant disease, provisional stenting was thought of. But there are certain problems. We need a long stent from LMCA ostium. I thought LMCA also has got disease, and stenting just from the ostium of LAD may not be a good, nice idea. So we need a long stent extending from the LMCA ostium to the LAD, and a 2.5 mm drug-eluting stent in LAD has to go to 4.5 mm in LM. LM is probably 4.5. And we need to jail a dominant 3.5 mm circumflex. And in case if you need a bailout stenting of the LCX, a 3.5 mm stent into the LCX has to go through the struts of 2.5 mm stent in the LMCA, which may not be a good idea. Then if you are going for two-stent strategy, clots, again, there was a gross disparity between the sizes of LAD and LCX, so clot may not be a good idea. Regarding DK crush, again, a mini crush was thought of because it's less complicated, it's lesser time consuming and better tolerated by unstable patients during primary PCO. We decided to go with mini crush. So you can see here in this second image, LM is more significant than what we thought. Again, we continued with that 3.5 mm EBU through the radial. Both LAD and LCX was wired. Using a 2.5 into 12 mm semi-compliant balloon, LAD was serially dilated. After that, a 2.5 into 43 mm drug-eluting stent was placed in LAD, and another 3.5 into 23 mm drug-eluting stent was placed from the ostium of the LM into the LCX. And after that, keeping 2 mm into the left main, the stent in the LAD was dilated. Following that, carefully pulling back the stent in the LCX, 2 mm into the LCX, close into the aortic ostium. The stent in the, after pulling out the balloon, the wire in the LAD was kept there, and this stent in the LMCA to LCX was deployed. Following that, a proximal optimization was done with 4 into 8 millimeter balloon in LM. Then a wire was crossed initially into the circumflex. While pulling back, it was crossed into the LAD through the distal most strut possible. Then the wire in the jail wire in the LAD was pulled back. While pulling back, the gate wire was pulled back just to avoid deep engagement and damage to the stent in the left main. It was pulled back. And the wire which was jailed in the LAD was pulled back and kept in the aortic ostium. This is to avoid further deep engagement of the gate and damage of the strut. After this, the LAD stent was serially post-dilated using a 2.7 into 12 mm non-compliant balloon, serially post-dilated. Then using a 3.5 into 12 balloon in the LCX and 2.75 into 12 non-compliant balloon in the LAD, a kissing balloon dilatation was done at high pressures. Following that, at 4.5 into 8 millimeter stent balloon was used to dilate left main, post-dilate pot was done into the left main, keeping 2 mm into, it was pulled back into the ostium and proximal optimization and the ostial flaring was done. After this, I didn't engage this gate into the left main again because I thought it may further damage the stent at the ostium, and this was the final result. Got a reasonably good result. The take-home message is during primary PCF left main bifurcation using 2 stents, mini crush technique is very useful as it is less complicated and less time consuming when you compare with DK crush and other techniques of 2 stent strategy. Thanks.
That was a nice case. The only thing is the circumflex to start with was absolutely normal.
Yes.
So when the circumflex is so normal, you did the circumflex, you wanted to stent the circumflex in anticipation of problems if you do a left main to LAD crossover stenting.
Yeah.
That is the only questionable point in the strategy here. Mini crush and all is okay. The circumflex, however dominant it is, it's so normal. Probably I would have had a high threshold to upfront consider a stenting of the circumflex. You could have done a crossover. Left main, picking up that left main was absolutely vital in this case. That is good. Yeah. Especially the LAO cranial view during the stenting process, it was very critical. And the clue in the caudal views was the left main was definitely smaller than the dominant circumflex. It was half the size of the daughter vessel. Yes. So obviously, without an absence of imaging, picking up the left main was a very creditable and very useful point that you made. But probably the need to stent the circumflex was a little questionable.
LAD was only 2.5. So I put up 2.5 mm. If you were going for this bifurcation or this provisional stenting, you have to choose the stent according to the distal vessel.
That's correct.
So
but then there are stents which can be blown up to 4. You can have
was
differential dilatation, right?
bit apprehensive. From 2.5, it has to come to the left main ostium. Then again flaring up. So
you did not have any imaging.
Imaging, it was.
No, so I think probably you are underestimating the LED. It's a diffusely diseased. So probably you can have a distal stent according to the angiographic. Then from LM to LED, you can put a bigger stent, like I would have preferred probably considering the size of the LCX also, A3 or 3.5, and then optimized.
Certain problems, this 2.4, 2.75 mm stent extending to ostium, then flaring, then if necessary, if we need a bailout stenting into the LCX, a 3.5 mm stent has to go through this start of this first stent. So maybe make it more complicated.
That's why LM to LED has to be a bigger stent. I thought probably considering the LCX size also, we could have taken a 3.5 or something from LM to LED, and the distal part of the LED from mid to proximal part of the LED could have stented with 2.75 or 3. And I would have not stented the LCX if possible, because LCX osteostenosis is high.
Bino, this is it's a type 3 LED. So many times when you evaluate type 3 LEDs with an IVUS or an OCT, you tend to see that even if the proximal mid LED is 2.75 or 3, most of the times the ostium of the LED tends to be at least 3.5. So looking at with those experience, probably if we had opened up the LED, given some nitro, and then probably gone with definitely it's an acute MI shock. You cannot do an IVUS or OCT late in the night. It's not possible. So extrapolating all these findings, a type 3 LED, mid-segment, you could go with a smaller stent, and from left mid, a 38 millimeter stent or so in the mid LED, coming somewhere near the ostium, leaving some 5-6 millimeters at the ostium, then go with a 15 or an 18 millimeter 3.5 stent from the left main ostium to LED would have been a reasonable option, provided if you had an IVUS or an OCT, then things would have been totally different. In retrospect, probably this would have been a reasonable option, I hope. 2 stents, one smaller distally and one bigger proximally. And I hope you have used a 7 French guide catheter, because you had
it was a 6 French.
6 French, 2 stents simultaneously.
I think that will be the last comment. Dr. Mangalan. Thank you, sir. 2 points I would like to add. See, in LMCA bifurcation disease, there's most of the time, more than 90% of the time, there is involvement of all the 3 vessels, especially the LCX ostium, if it even looks apparently normal. So actually there is no problem in sending into the circumflex. Another thing, there are stents, 2.5 or 2.75 stents, which can be post-dilated to even up to 4.5. So you have to look into the manufacturers and bench data. And the only thing, you should have such kind of stents in your inventory. Thank you. I think most of us agree with the fact that in the middle of the night, a complex procedure is to be avoided as far as possible. Generally speaking, the feeling is that left circumflex, maybe you could have had a wait and watch policy and stent from the LED, one stent, and LM to LED a second stent. Probably that's what most of the people feel. But excellent case, nice. Thank you.
We are having a presentation by Dr. Matthew Paul, a complex case of LM stem managed with support of IABP.
Respected chairpersons, middle of the night, a 57-year-old male, he presented with acute onset chest pain. His ECG showed all features of left main occlusion, and his echo showed regional wall motion of abnormalities of the posterior wall, lateral wall, and inferior wall. He had a moderate LV dysfunction, and he was in cardiogenic shock. So looking at the patient, he looked very sick. So we intubated him and started on all inotropic supports. And this was the angiogram. The right coronary artery showed a proximal disease, and the left main just a stump. Now, when I took the access, I took bilateral femoral access with the thought that probably I may have to use an IABP because he was on all complete inotropic supports. So now my aim was to wire into both branches. So patient was very sick. Even I was very terrified at that moment. So like I used 2 wires. I didn't know where it went. So I thought it was in the circumflex and LAD. And when I took the cranial view, I found that one wire was in a diagonal and the other wire was in a septal. So now I have to open up a circumflex, went to the LA caudal view and opened up the circumflex. Wired the circumflex. Now there was flow in LAD, but at the same time, there was no flow in the circumflex. So dilated the ostial part of the circumflex with a 210 semi-compliant balloon. No flow was established. Used a longer balloon and got a flow. But now I found that the major OM was having decreased flow. Now what I did is, patient was on supports, maintaining around 80s systolic blood pressure. So after establishing flow in both LAD and circumflex, I used an IABP through the left femoral axis. Patient had VF reverted, patient had AF reverted. Then a kind of stable patient was after all these things. Now I pre-dilated the mid part of the LAD. So I felt that I have some breathing space at this moment. So now I was thinking what to do. So anyway, I have to stent from left main to LAD. And regarding circumflex, I was just thinking like at this moment, I should make it as simple as possible. So first I stented the mid LAD and then from left main to LAD using a 2.518 stent in the LAD and 3.518 stent in the left main to LAD. So this gave a reasonably good result, but in the LAO caudal view, the flow in the circumflex was not as good like the LAD. And when I did the echo in the beginning, the regional wall motion abnormality was more in the circumflex territory than in the LAD territory. So I felt that I have to stent. So at this time, now what bifurcation strategy has to be taken? That was in my mind. So since the angle was very favorable for a T stenting, I put another stent from the OM to the LM. So placing at the tip of the left main to LAD stent like a T. So after stenting, I pull back the same balloon back into the left main, used another 312 semi-compliant, non-compliant balloon from left main to LAD and did the simultaneous kissing dilatation. So with this, I got a reasonably good result. I didn't do a port at this moment because the left main looked all right and I didn't want to do further dilatation in the LAD because now I have a good flow. The distal LAD is diffusely diseased. I didn't want to make it perfect. At this moment, patient looked all right. He was hemodynamically stable. The ECG was also all right. And he was shifted back to the ICU. He had a cardiac arrest in the ICU, but with CPR 2 cycles, he was stabilized. 3 days of IABP support, 7 days of mechanical ventilation, 12 days hospital stay. And I was fortunate enough to see him yesterday in my outpatient, and he has a mild LV dysfunction, leading a normal life. So when left main occlusion is suspected, and if there is a hemodynamic compromise, prior intubation is better. When there is a single operator, when to put IABP is the question. So since I had 2 access, like both femorals, and once the flow was established in both vessels, I put the IABP and make the procedure as simple as possible. And when TIMI3 flow is established, better not to go for aggressive post-dilatation. Thank you.
Nice case. I'm sure you must have secreted a lot of catecholamines during this procedure. One small doubt in your last but once. What is CPCR?
Cardiopulmonary.
Cardiopulmonary? Cerebral resuscitation. That's a current term, is it?
So when you did you did a tap from circ to for that circ you did a tap. But then when you do a tap, it will be better to put a balloon into the LED first. There was no balloon in the LED there because once you protrude it and deploy it, maybe sometimes difficult to take the balloon down. So
I was not intending to do any sort of protrusion. It was just at the tip. It was a T-stenting. I was not planning to put any stent strut to the LM.
and even then, by chance you come. It is very difficult sometimes. So it is always anyway. You are going to do a kissing balloon after
So
that.
I didn't have any plans of doing any heroic things at that time.
You did a kissing?
Yeah, I did it. I did it, but I didn't have any plans. So I was totally blank at that moment.
One thing which we could have done in such a case is do a left main final dilatation. The left main, the TIMI3 flow you have established. The patient has become much stable, but still there was probably you could have done it even better if you have dilated the left. What was the final balloon in the left main?
So it was 3.5.
That is maybe a 4 millimeter. Looking back.
Yes.
Anyway, for that particular case, in the middle of the night, with
Great.
a non-visualized, just a cul-de-sac of the left main, having attained that kind of a result is very, very creditable. Congratulations, sir.
Very good. Congratulations.
Matthew, small question here. Would you like to call back the patient in the pretext of an imaging and do if required for the long term?
Because the right coronary artery had a disease, I had planned to
I'm just asking.
even with imaging. But then because of financial constraints, he had gone to another center and got the RCA done.
So you are a very expensive cardiologist.
Or
he has exhausted all the money in your hospital. The two differential diagnoses.
The thing is, he had to spend a lot of money by the end of 2 weeks. So he had no plans to come back to me for the second procedure. But then he asked me permission to go to another center to get it done.
Well done, Dr. Matthew.
So next case is by Blessin. Blesvin Gino is presenting a case of interesting case of acute MI intervention, therapeutic dilemma.
Hello. Now this will be a modification of the how do I do session. So in between, we will actually pause those slides and Natarajan will be discussing this case. We have about 18 minutes, including the presentation. And feel free, Natarajan, controversies are always welcome.
Especially when the case is done in Dr. Pradap's center. There is bound to be controversies, celebrations, and excitement. So, yeah, we'll have.
Good morning, one and all. I am going to present an interesting case of STEMI. There were a lot of therapeutic dilemmas in that case, so we thought of presenting this case. So our case is a 36 years old male. He has a history of dyslipidemia. He presented to our center with a history of chest pain of 1 hour duration. And ECG showed ST elevation in V1, V2 and lead 1 AVL. Echo showed anterior and anteroseptal hypokinesia with EF of 40. So this was the ECG. You can see clear ST elevation in V1, V2 and lead 1 AVL and a reciprocal ST depression in inferior leads. So this patient was taken up for primary angioplasty and this is a right coronary artery angiogram. RCA was non-dominant, having minor disease, and it gave collaterals to the left system. And the left system, it's a circudominant system and Australia led total occlusion. So we started the procedure. We initially took a right radial approach and a 6 French EBU 3.5 catheter was taken and we approached a lady with a BMW wire. And
Blessman, can you show the first left injection before the wiring? Can you run that? Okay, go on.
Yes. So we took a right radial approach and 6 French EBU 3.5 catheter and we took a BMW guide wire and we crossed till the
LED, but we could not proceed further. So we thought we'll do a daughtering. And after daughtering, we could establish flow in the septal artery and major diagonal. And we can see the LED vessel, but again and again that BMW wire was not crossing into the LED. So you can see that this is a BMW wire, and wire has to go like this, but wire went like this, but the original course was on the red line. So we tried for 15 minutes. We could not cross. So patient was having ongoing chest pain. So we thought we will dilate the proximal lesion to establish a better flow. And in between, we changed BMW into filter FC also. So after dilatation, then we thought we will attempt another course, because again and again the wire was not going to the distal LED. We thought there may be another course in the red line. You can see that through the septal artery there might be another course. So we thought we gently poked with the filter FC wire, because we were not very sure about the course. So we gently poked with the filter FC wire. Again, it was not going. So we dilated the proximal lesion. So there was some relief in chest pain. Then we switched over to the original first course, because whatever we could see, that was the first initial way. Yes.
The thing is, the RCA was normal.
Yes.
And the distal LED was collapsed.
Non-dominant.
Normal. Non-dominant, normal. Okay. Okay, correction. Madhu, thanks. So, non-dominant, normal, and it was feeding the distal LED.
Yes.
Right. By definition, ST elevation MI is ATO, acute total occlusion.
Yes.
Right. There is no controversy in that. So, you did not visualize the LED at all. And if you remember, if you see now, at least in this frozen frame, there is a giant of a first septal branch. Your ECG was very classic of an LED occlusion proximal to a first septal branch.
Yes.
You had ST elevation in AVR, you had ST elevation in V1, and you had ST depression in inferior leads. So it was very classical of a very ultra proximal LED. And the septal is a huge branch. So the possibilities are, one, it was probably a critical stenosis in the LED to start with. And that must have got occluded suddenly and causing the myocardial infarction. And probably during the process of wiring, etc., sometimes even during an MI, we can dissect the LED. So you will not have access to the distal LED thereafter. It's very unlikely that it is a CTO of the LED causing a ST elevation myocardial infarction, maybe a dissection. During the process of the angioplasty, we can dissect the LED, and thereafter wire access may not be possible, or it could be a CTO of the LED, with the current culprit being the first major septal itself, because your ECG pertains to that. These are the two possibilities.
Yes. We also thought the same thing. That is why we dilated. When we could not wire distally, we dilated the proximal segment to establish flow to the major diagonal and septal. So at this stage, we thought we'll attempt once more through the initial way with the Gaia second. So we switched back to the original route, and again Gaia wire went to the lateral side. It has to go through this route, but it was not going. So what to do now at this stage?
At this patient, I'm sure the patient at this time was quite stable.
Yes, sir. There was
all the instability is gone at this point in time.
Yes,
that is a very reassuring thing.
Yes.
You have opened the proximal LED. There is good flow into a major septal, and there is a huge, large territory diagonal,
Yes.
and the patient is kind of settling down.
Yes.
And I'm sure the ECG changes could have subsided by now. These are all very encouraging signs.
Yes.
Madhu, you wanted to ask something?
Yeah. So what would you do? That's the second therapeutic dilemma that you had.
Yes.
What would you have done at this point?
See, all of us will make all kinds of efforts possible in as quick a time, especially when you're dealing with ST elevation myocardial infarction. Keeping it simple is the way to go in an ST elevation myocardial infarction. So if the patient is rock stable, how much time has been spent already in wiring this LED?
Almost 30 minutes, sir.
So we are spending a lot of time trying to recanalize an LED, which is increasingly becoming more and more difficult.
Yes.
and you have established flow in the proximal LED into that Y kind of diagonal and septal. So you can always stop at this point, even with a balloon dilatation or a stent into the proximal LED, and we can reassess the patient later on, provided the patient is stable. If the patient continues to have chest pain, ST depression, ST changes are continuing at this point, you can pursue more efforts. In an ST elevation myocardial infarction, the job should be done in 15 to 20, 30 minutes. You can't be struggling to wire an LED for more than 30 minutes, 45 minutes, 1 hour. That is probably not recommended.
Yes, we also thought the same.
Sorry, Nadrajan, yeah. So, yeah, whether you would have left it as such with a balloon or would you have stented?
I wish I had more images. You at this point you have some angiograms.
Yes, sir. So
is it a good result?
So we also thought the same, and we might have dissected the middle lady. So what to do now? It's already 30 minutes over. What's the plan now? The option is either we have to send the patient for emergency CABG. The problem with emergency CABG is a high risk procedure, and mortality is more, and the complications of acute kidney injury and ventricular arrhythmias are more. And another thing is stenting the proximal segment alone. Then septal artery and diagonal will have good flow, but again the chances of stent thrombosis may be there. So and circ is the dominant one, so we don't want to leave stent the proximal segment alone. And another thing is just do POBA and leave it. So POBA is a good choice, but the problem is recoil is there. And
Even in this frozen picture on the left side, you can extend it backwards. There is some haziness in the most proximal LED. I think if the patient is very stable, with this kind of a distal runoff into two major branches, the diagonal is really a big vessel, the diagonal and the septal. I don't think you need to have that much of concern about stenting this proximal vessel. Patient will be fine. I would take the risk and probably stent it at this point. I'm sure you must have done something differently. Being with Dr. Pradap, I'm sure you will not be happy with this result, and I know what brings happiness to all of you. Yeah.
So if technical expertise is there, then we can go for such to retrograde approach. So these are the problems with emergency CABG: high mortality, high usage of off-pump procedure and on-pump procedure, and increased perioperative bleeding because patient is preloaded with dual antiplatelets, and total arterial revascularization may not be possible. And POBA is high chance of reocclusion, and stenting in the proximal segment alone leads to incomplete revascularization and the chance of stent thrombosis. So before going to switch over to retrograde approach, we tried another filter FC because we thought the filter FC might have lost its profile. So we changed to another filter FC, and we changed the angle also. We could not get anything new. So we changed to a crusade. Now we thought we'll give more support to the guide wire with the help of microcatheter. At this point, we thought crusade will give better support than the fine cross or other microcatheters. So we popped the crusade in the diagonal, and through the this another OTW wire, then we took Gaia third. We thought we will have better penetration force. So again, we could not succeed. Then carefully analyzing the another angle, caudal angle, we saw that we were going in a wrong route. It's a different route because we already tried in the septal route also, but it was not successful. We could not forcefully penetrate the septal artery because it was a huge artery, and any damage to the septal artery may lead in complications. So we thought at this point of time, retrograde is the safest approach.
Let's spend 1 minute.
Yes.
Nadrajan, your comments now. What would you have done now?
See, as we already mentioned, it's very unlikely that it's a CTO, unless you want to do retrograde, thinking of a dissection in the antegrade route, which is standing in the way of your angioplasty. A stable patient in a ST elevation myocardial infarction with completely settled ECG changes, with such big septal and diagonal, I don't think, at least I wouldn't venture into anything more. I'll be happy with what has already happened. The patient is stable, everything is fine. You can always take the patient for another day and recanalize the distal LED.
Yes, the patient was stable, but again, not completely pain-free. Some amount of pain was there. ECG was partially settling.
Too much of efforts also sometimes can make the patient painful.
Dr. Nadrajan? Dr. Nadrajan?
Yes, please.
It's excellent discussion. My question is to you. You said you stop here. Patient came with HTMI. With how can you stop here? One. Second thing is you said stenting of the proximal LAD. How can you do stenting of proximal LAD in the presence of distal dissection with no flow in the distal LAD? So this is a time somehow you to cross that dissection, whether it's with the imaging, double wire technique, dual lumen or retrograde. That should be our approach.
Provided that is the distal LED is the culprit. We don't know. We are not sure.
See, if you look at the first angio, the right injection shows that the distal LED fills up to the mid. So it is suggestive of a CTO initially itself.
Sir, I would also look at the echocardiographic images. If you had a reasonably contracting apex, I would certainly take it as a CT of the middle lady.
Yes.
And you had a major diagonal, major septal producing an MI, open up the proximal segment. Then, if at all, as Sir has pointed out, short stent in the ostium, not reaching till the bifurcation, and you probably can do a retrograde CTO at a later date.
There is a
So
good flow.
I would look at the echocardiographic images also.
There is a good flow to the septal and diagonal also. So there is no problem of stenting because distal flow is not there as.
Yeah, as Dr. Deepak very rightly mentioned, a short stent, wherever you find that the haziness is more, isn't a wrong idea. Because already 30 minutes passed.
Yes, sir.
Maybe now 45 minutes passed.
Yes.
Or maybe even 60 minutes passed.
30 minutes.
So we have exceeded the time of actually myocardial salvage. So Dr. Ashokan's point is well taken, provided the distal LED is indeed the culprit. We really don't know. Recently we had a similar patient who came with ST elevation with echocardiography features of apical ballooning. All right. And we did the angiogram because the patient had some chest pain, troponin leak. And we found that there is exactly where the LED is occluded. Despite all the antegrade techniques, we couldn't recanalize. So we gave it up. 2 days later, the LV function was normal. So it was probably a stress cardiomyopathy superimposed on a CTO of the LAD. So just because an LAD is totally occluded during the context of an ACS, if there are alternate explanations possible, you need not worry too much. That's the point.
Yes, sir. Here the point is we wanted to, if you stent the proximal segment, we didn't want patient to have stent thrombosis because circ is a dominant one, and we didn't want to take the risk. And another thing is, problem here is another advantage of in-house center is we routinely do retrograde approach. So we have the technical expertise with minimal contrast we can do. We used to do many zero contrast angioplasties also. So we thought we will give an attempt of retrograde approach.
There are more, always for anything in life, there are more ways than one to do a procedure. So as you correctly said, if the patient is rock stable, hemodynamically stable, etc., why not go further and make it a perfect result? Isn't totally wrong. We are only discussing. I was only trying to say
Yes,
that
sir.
in the context of a STEMI.
Yes, sir. If technical expertise
What
is not.
I see, you should always look at the coin on both sides. So
Yes, sir. If technical expertise is not there, I would have stopped here.
yeah, so we recognize your technical expertise. So you can tell us what happened next.
Yes, please. So to be successful, either we have to go retrograde. Another approach is we can do IVS guided proximal cap puncture, which is little tedious at that point of time. So we thought we'll go retrograde, and we took a right femoral artery approach. For dual injection, we have to take a right femoral artery approach. So we thought we'll approach the coronary through the femoral with sound French EBU catheter. We changed the catheter to sound French EBU 3.5, and we took the dual injection, and it showed we gave two important information. Number one is there was no intervention collateral from the right coronary artery because the collateral was tortuous, long, and the size was not good. And the second information is the proximal cap was really ambiguous. So we don't know where is the cap. It may be from the septal artery, or it may be from this diagonal, or it can arise from this area also. So there are three possible routes. So the proximal cap is really ambiguous. So we thought we will go through the ipsilateral collateral, and we crossed the septal artery with the fielder FC, and we initially took a fielder FC with fine cross, then we switched over to cyan black. So these are on careful look, you can see there was a septal to septal collateral which had acute angulation, Another collateral was for LPDA to LAD. So because of the acute angulation, we thought we will go through the yellow line. So we took cyan black with the fine cross, and we did the septal surfing. So after that, then the cyan block entered the EBU. Then the next step is fine cross pushed into the same catheter. It's basically a single catheter retrograde CTO with through ipsilateral collateral. So fine cross was taken into the EBU catheter, and then we exchanged, the externalization was done with the RG3 catheter. Then another important crucial point at this point of time is pulling back the microcatheter into the septal channel. That will pull the guide catheter, and you make create a dissection of the left vein. So at this point we have to be very careful, and you should not create any dissection because left circle is the dominant one. So then we dilated the mid-LAD lesion with 1.5 into 15 mm balloon, and then to our surprise, our initial second thought, the LAD course was through the septal artery. We were all the way trying through the another route. So this was the original course. That initially we did not try with force because we didn't want to dissect the septal artery, but that was the original course. So this was the correct course, and this was the wrong one. Then we did the IVS to confirm our position, and the entire course was intraluminal, intra-block position. So the measurement showed distally 2.6 vessel diameter and proximally 4 mm diameter. The length was 46 millimeter. We dilated the mid-LAD lesion with 2.75 into 12, and we stented the proximal segment with 4 into 23 and distally 2.75 into 23. And then we dilated the proximal segment with 4 into 8. Then we did the IVS again. There was a reasonably well expanded stent with no edge dissection, and there was some mild under expansion there. Otherwise, overall good result. Then we dilated that area with 3.5 into 12 balloon at high pressures. So this is a final result, and the procedure time was little long, the 110 minute, and fluoro time and radiation dose was little high, and total contrast was 260. The patient did not have significant rise in creatinine on till third day. Patient was discharged on the fourth day in a hemodynamically stable condition with full revascularization. So lessons learned in this case is retrograde approach really helps in the ambiguous proximal cap. Other ways, if technical expertise is available, then another possibility is IVS guided proximal cap puncture. And collateral channel selection is very crucial in success of retrograde approach. Single catheter retrograde approach is technically very challenging, and operator experience is essential to succeed. Thank you.
Can you keep the lessons learned? No. Yeah. See, in your final conclusion, there is not a single word about ST elevation myocardial infarction. See that? It's all about CTO. So the key of persistence opens all doors closed by resistance. Okay, that's a nice conclusion. So at the end of the story, you still believe that the distal LAD was the culprit, or is it only the proximal
No,
LAD?
the
which was
proximal LAD is a culprit. There is no doubt about it. Proximal LAD is
you
the
wanted
culprit.
to avoid stent thrombosis, etc., by only opening that.
Yes.
So patient is very stable, so you could do it in quick time.
Yes.
Yeah. So that is acceptable.
Yes.
But most of us would have probably stopped because we don't have that much of a technical expertise in retrograde PCI. And in the middle of the night to do such a heroic effort.
Not in the middle of night, evening time.
Pardon?
Evening time.
Evening time.
Yeah.
So that does it mean that if it is in the middle of the night, you wouldn't have done this?
No, if our
No,
time,
honestly tell me. 2
No,
a.m.
we
in
will
the
do.
night. You'll still do
If
this.
sir is there, we will do, sir.
No. That's a very good point. If he's not there, what would you do?
I would have stopped on the proximal stairs.
That is exactly. That is the best way to do actually. So we had a wonderful case from Meditrina. Thanks to Blesswin as well as Dr. Prada for that nice case and evoking a lot of discussions, creating controversies, not creating, having discussions on controversial areas. So we all enjoyed that presentation. Thank you very much.
Thank you, sir.
I had an equally good discussion by Dr. Nadarajan. He made it very lively.
Thank you, Nadarajan.
Thanks everyone for that wonderful, really wonderful discussion. Thanks.
Just while you're discussing, to Pradap, in such a case, if when a ostial occlusion in an acute MI, how safe it is to intervene to a dominant circ through a retrograde channel with 260 ml of contrast for an ACS lesion clinically stabilized after the ostial dilatation. Patient clinically stable, distal lead is filled by retrograde collaterals. You are intervening through a dominant circ through a retrograde collateral with a fair chance that you might injure a fully flowing circ in an occluded lady who patient was presented with.
Well, actually, no comments. Basically, I think the wire is easily gone there.
No, sir, it's for all of them.
No, I'm just telling actually a very large circumflex, taking a fine cross catheter with a small wire there. I don't think that will cause anything if you are very sure about the wire is going into the true lumen. If you are suspecting that your wire is taken in a dissected segment, it is okay. Just taken the wire. You should actually, retrograde is basically of clearly identifying which channel to go. Otherwise, you just surfing down there. I was very clear which channel is there. I taken the wire immediately gone there.
In the interest of time, Pradap.
I stopped.
Thanks, Amay.
I stopped.
We'll go to the next session. Yeah.
Thank you.
Thank you, Anandal. So now we'll move on to the next session, LMCA interventions. May I request the chairpersons, Dr. C.G. Bahlin, Dr. George Koshier, Dr. Ronnie Matthew, and Dr. Rupesh, please come forward to the dais and occupy the chair.
Okay, so I think we start off with the LMCA interventions. We got 7 very interesting cases. So let me invite Dr. Shyam Shashidharan. Imaging guided complex left main intervention in a case of high surgical risk. 7, isn't it?
Good morning, everybody. I'm presenting the story of a 46-year-old gentleman with history of NSTEMI, diabetic, post PCI to circumflex in 2018 at another center, presented to us with STEMI, extensive anterior wall MI in pulmonary edema on December 2022, and he underwent primary PCI to proximal LAD, total occlusion. This was the angio at the presentation. You can see the LAD was totally occluded proximally. There was a very tight ostial circumflex lesion as well. And this was the image after the primary PCI to LAD with a 3.5 to 28 signs alpine. There is an LMCA bifurcation lesion, circ OM bifurcation lesion. And you can see the previously implanted stent in the distal circumflex has a very critical ISR, almost flow limiting. And RCA has a diffuse disease from proximal to mid part. So after the primary PCI and settling the acute pulmonary edema, he was evaluated for elective CABG for LMCA bifurcation, LCX and ISR and RCA lesions. The patient did not accept high surgical risk explained by the surgeons due to poor LV function and was followed up medically. He presented again with worsening effort angina class 2 to 3 after 6 months, and he was taken up for a repeat angiogram, which showed again the tight LMCA bifurcation disease. LAD stent was widely patent, and the circumflex ISR was there. So at this point, after a detailed discussion, he was taken up for an imaging guided PCI. So the challenges were impaired LV function, 2 major ACS in the past, a stent failure, LM bifurcation disease, a circ major OM bifurcation disease. So the plan was to do an IVS to the LCX ISR and a probable drug-coated balloon depending upon the cause of ISR, and a provisional stenting strategy to LCX OM, probably tap because of the favorable angle, and a DK crush to LM bifurcation, PCI to RCA. Mechanical circulatory support would have been ideal, was not available. So the imaging to the circ ISR clearly showed that the previously implanted stent was undersized. The vessel is anyway from 3 millimeters. The previously implanted stent was 2.5, and the lesion in the circ extended to the ostium. So the LAD IOS evaluation showed a well expanded opposed LAD stent and the ostial lesion of the LAD had a circumferential calcium 360-degree, but the US calcium score come as 1, so we thought that extensive calcium modification might not be necessary in this case. So we proceeded with the pre-dilating the circ ISR with a 3 into 12 NC at 18 atmosphere, followed by a drug-coated balloon paclitaxel clotted agent 3 into 15 at 6 atmosphere into 60 seconds. This was the result. There was some distal spasm. Then the circ, we had a distal landing zone with a plaque burden of 37%, and the ostial MLA was 2.2. So we proceeded to the circ stenting after pre-dilatation with 3 into 12 NC. So the circ, we decided to keep a 3 into 38 synergy and with a 4 into 12 NC at the LAD with enough protrusion into the LM to facilitate a proper crush. So the stent was deployed, and after stent deployment, a check shot was taken to ensure there was no distal dissection. And in this particular case, the flow to the major OM was okay. So we could do with the provisional stenting at that part. So both the wires from the circ and OM were removed, and LCX stent was crushed with an appropriately sized 4 into 12 NC. And LCX was recrossed through the proximal struts, post-dilated with 3 into 12 NC at high pressures, followed by kissing by balloon inflation with 4 into 12 NC in LAD and 3.5 into 12 NC in circ. Now coming to the LAD stenting strategy, obviously the distal part would be the standard part, and the LMCA diameter was around 4.75. So we took a 4 into 24 DUS from LM to LAD, placed it, and second crush was done after removing the circ wire. Now before rewiring the circ, the first port was done with 4.5 into 12 NC. Then the circ was rewired. LAD was post-dilated 4 into 12 NC at high pressures, followed by 4 into 12 NC in LAD and 3.5 into 12 NC in circ at 12 atmosphere. Report was done with 4.5 into 12 NC at 12 atmosphere. This was the result. So the post-stent analysis showed well-expanded stents in the circ with the MSA averaging at 8. And you can see in the longitudinal section beautifully the new metallic arena. And LAD, again, good MSA, both in the LAD and the LMCA. And the minimal, the crash circuit strengths can be seen in the last picture. Proceeded with RCA IOS evaluation routine only. So there was a distal landing zone. MLA was 2.65, standard with 3.5 into 48 synergy distally, followed by 3.5 into 12 synergy proximally. So that was the result. Post IOS showed good appositions. So the take-home message is intravascular imaging along with meticulous technique and right hardware goes a long way when it comes to a high-risk LM bifurcation intervention, particularly in patients with LV dysfunction. And this case demonstrated the role of IOS and DCB in managing stent failure. IOS plays a crucial role in optimal vessel blood preparation, vessel sizing, ensures stent coverage of ostia, optimal crushing of stent, assessing the carinal shift, and correcting under expansion and malapposition. Thank you.
I think it is a nicely done case. Well, of course, this patient has got multiple stents, complex procedures in the left main and the right coronary artery. Any day surgery would have been a very good choice in this case. And as usual, the statement is that patient refused surgery and we go for such
Actually,
a complex
the
procedure.
patient was sent to Srijitra, sir.
Yeah. Rightfully, you have used the combinations of drug-coated balloon as well as the stents. That's a very good strategy in this patient. And probably DK crush would be a choice for the left main to circumflex and then provisional strategy for the OM. They are all good. Strategy-wise, they are all good. And imaging, this sort of complex cases should become successful and effective only if you have an imaging support. Because when you do the bifurcation, the main aim is that you have to have a good expansion of the stents in the main vessel and expansion and coverage of the ostium, and the carina should be shortest as possible. and not committing to either branches with a good confluence, polygon of a confluence. That is what is expected. I only find that there is only a passing picture in the IVUS. The carina seems to be longer one in this particular case. That's what I said. Neocarina was a longer one. In fact, among the two stents techniques of bifurcation, DK crush is the one which results in the smallest, shortest carina. But here it was longest. Probably your stent protrusion, the first stent protrusion from circumflex to the left main might have been longer than what should be expected. Nowadays, it is coming shorter and shorter, unlike the classical one. That's only my comment.
Yeah, thank you. Thank you very much for this great case. Now, I think invite Dr. Vinay Kumar. He's going to speak on reverse culotte with crush in late stent malapposition of LMCA. Okay, Dr. Pranav is going to be here. Okay.
Good morning, everyone. First of all, I would like to thank my sir and Icck for presenting this case here. My case is reverse culotte with crush in late stent malapposition of LMCA stent. So our case is a patient is a 53-year-old male who is a chronic smoker and dyslipidemic. He presented with anterval MI in 2021, and after 1 month, we did an angio. It was a 2-vessel disease. So we did adopt PCI to osteal LAD with 3x33 stent. And after 2 years, he presented with effort angina in the OPD. And echo, there was no RWMA, and ejection fraction was 60%. So this was the angio taken. So which is showing a significant LCX osteal disease, almost near total occlusion. And there is a significant disease in the LAD ostium. So we decided to do a dedicated LM bifurcation. So we took a 7 French EBU 3.5. So LAD we wired with a run through with fine cross microcatheter support, and we wire into the distally. And there was difficulty in wiring the circ. So with fine cross microcatheter support, we wired circ with the fielder XTA, and wire we exchanged with the run through wire. So with the clear stent image, we can see the previous stent was covering the LCX ostium. So our first wire, which is going into LAD, it is through the strut of the first stent, and circ wire is also through a struts. So here, initially we decided to fix the circ lesion. So we pre-dilated the OM with a 2x10 semi-compliant balloon, and again we pre-dilated with 2.5x12 NC balloon. So distal OM we stented with 2.75 into 28 Everpro stent. Initially we found difficulty in tracking the stent, but somehow we got distally, and we fixed the distal lesion. Now the main difficulty was to stent the bifurcation. So initially we prepared the this bifurcation with the balloon crush. So we kept 2.5 into 10 NC balloon into the LAD and 2 into 12 SC balloon into the circ. And we did we crushed the malapose stent part with the balloon. And then we took 2 stents, and here we decided to plan a V stent, and we put 3.5 into 18 Everpro in the LAD and 3.3 into 15 Everpro into the circ. And simultaneously, we deployed the balloon in the bifurcation. So here also, we crushed the malapose stented part here also. So we removed both we took back both balloons, and again we did the kissing balloon with the same stent balloon. And this was our final result. So in classic culotte, these are the classical steps of the culotte stenting. Here we see the overlapping part is in the LMCA. But in our case, here we can see, in our case, this was the malapposed part. And here the overlapping segment is into the LAD. So we called it as a reverse colloid. And here we finished the LMCA bifurcation with the V stenting, and this was the crushed part of the stent, malapose stent. So the take-home message is late stent malposition. The incidence is 12% in a drug-eluting stents. So predictors of late stent malposition is total stent length, primary stenting in acute myocardial infarction and CTOs. So the causes of possible mechanism for late stent malposition is decrease of plaque behind the stent because of our plaque, because of intensive statins, or in case of acute MIs, if there is thrombus, it may dissolve after some time. So there is decrease of plaque behind the stent. Then positive vessel remodeling and rare cause like chronic stent recoil without any change in the arterial dimensions. So the disproportionate size of LM, LAD and LCX percent interventional challenge in LMCA true bifurcation stenting, and reverse colloid with balloon crush and V stenting bailed out from LMCA stent, late stent malapposition. So amalgamation of different stenting techniques need to be considered in a rare situations. Thank you.
Now, I don't think you can call this late stent malapposition, because it's, first of all, it is a stent that has been malaposed from the very start, because the port has not been done to the LAD stent to oppose it to the left main. So that's point number one. And second is, you have crossed into the LAD through the side of the stent.
Yes.
And you have crossed again into the circumflex, again through the stent struts.
Yes.
So it is not theoretically a crush. What probably we should have done is, you should have done a pot
So
first,
here-
after going into the LED, crushed it, and then gone for a T or something.
So
Here now
here-
you have a huge metallic carina there.
So here pot is difficult because LMCA size was a very big, and LAD and circ size were a bit smaller.
No, I want you to think about it. If you have got a stent over there, you have crossed into the stent to the LED, you have crossed through the stent into the circumflex. When you kiss it, the entire metal comes into the neocarina.
Yeah.
Right? So the first stent, 50% of the metal is the metallic carina. And now you've got another V stent. So you have 4 layers of stent in the metallic neocarina. To prevent that, maybe just cross into the LED and crush that stent into the circ and then cross. So
Yeah, I also think so. The important point is that you have the strategy. It is a projecting stent across the circumflex. You can either if the size is okay, then you can dilate it and make a culotte, classic culotte, and correct it. Otherwise, it is a crush. If it is a crush, then it's very important that the wire crosses outside.
So because
Not
the wire
inside.
was not going, that's why.
No, yeah, it has to go outside. Then it crush to the opposite wall of the left main. And then to know that the wire crosses, IVUS helps a lot. It's a very, very important thing that IVUS should be done, and verify that the wire has gone outside the stent projecting into the across the circumflex. So these are the 2 techniques which would come to me.
I think the important issue is the size disparity.
Yes, yes.
The LM is around 5 millimeter and the
LAD
LAD and
is
circ are relatively small. This is neither a crush nor a sort of, because it has gone partially, and I think the main issue is a lot of metal which you can see.
One question. The final picture is very good. You animate it very well. But if you have to re-intervene in the circ, it looks like almost like a small SKS into the LM.
Yeah.
If you want to, it's not V, it's protrude out, and you have crushed the final malapost and also to one side. So and that's the. See, if you want to re-intervene in an SKS, it's different. You can still crush, but you don't know where your malapost end in the LM has gone. It might still have gone to one side of the circ. So you might be going through very complex layers when you want to re-intervene in this circ. Not just pure SKS also. You have SKS with a malapost stent from LAD crushed to one side of the LMCA, which we are not very sure to which area it would have crushed through.
So we crushed it into the carina. Both.
So it's actually, you have crushed it 2 stents actually. And how do you think you would intervene later on to this circ would be?
Yeah, that's a story later. Thank you very much for your presentation. I think we'll go to the next one. Dr. Manu will be presenting on OCT guided LMCA bifurcation stenting by DK Crush.
One announcement, sir.
No.
We do not have a separate coffee break. Coffee is available on the right side hall. Those who want to grab it, please just do it. Yeah.
So good morning all, respected chairpersons and dear friends. I'm presenting case of OCT guided distal MC bifurcation. Patient is a 54-year-old female. She presented with inferior LMI. Angiogram showed LMC disease plus 3-vessel disease, and she underwent a primary PCA to RCA and later posted for elective PCA to LMCA. You can see that angiogram LMC distal LMC true bifurcation lesion. And the syntax score is intermediate. Syntax 2 score favors CABG. Patient choice is PCI. So we proceeded with LMC bifurcation PCI. And for any bifurcation PCI, as you know, you have to first classify whether it is in a simple lesion or a complex lesion. And for an LMC bifurcation lesion, complex bifurcation lesion, the side branch ostial lesion severity should be more than 70% and the length is more than 10 millimeter. And if it is a complex LMC bifurcation lesion, data favors an upfront two-stent strategy, that is DK crush technique. So a complex LMC bifurcation lesion, Medina 111. So we proceed plan for a DK crush technique with an imaging gating support. Of course, for LMC bifurcation lesion, IVUS is the gold standard, but here there's no significant ostial involvement of LMCA. Only a distal LMC involvement, and OCT is feasible as demonstrated by the element study. So both lesions were wired, and first we did an LMCA to a lady OCT run. And we showed a tight lesion at the ostial LAD with MLA of 2.1 and 19 millimeters squared and distal LMCA MLA of 3.53. And morphology mainly shows a fibrotic plaque with a spotty calcification, calcium limited to less than 90-degree arc. So the lesion can be managed with a cutting balloon and an NC balloon. And OCT delineated both the distal reference and proximal reference diameters, and the lesion length also noted. Then we did an OCT of LMCA to circumflex run. We showed an MLA of 1.05 millimeters squared distally and a tight lesion at the ostial circumflex. Again, the morphology shows basically a fibrotic plaque with a spotty calcification. And the lesion length and the reference vessel diameters and stent diameter chosen based on the OCT reference vessel diameters. And then we pre-dilated both the LAD and circumflex lesion with both cutting balloon and NC balloon. And then we just stent the circumflex with a 2.75 to 33 millimeter stent with a 1 to 2 millimeter protrusion into the LMCA. And this is the second step, the side branch optimization. After deploying the side branch stent, the side branch balloon should be withdrawn and should be deployed at high pressures to optimize the side branch ostium. And then we did a first crush based on the distal the LAD diameter. Then we did a pot crush, the first pot crush with the balloon based on the proximal main vessel diameter that will be placed up to the carina. That will produce a complete crush and will prevent the abdominal crossing. Then we did a first non-distal recross, basically proximal to mid-cross. And this is the distinct advantage of OCT, which will clearly localize the crossing points. Here you can see that the crossing is mainly in the proximal part, not in the distal part. Then the serial pre-dilatation of the serial post-dilatation of the side branch ostial stub, and followed by first kissing balloon dilatation. Then we deploy a stent from LMC to LAD, followed by flaring and first spot. First spot also the balloon, the distal short of the balloon to be up to the carina. Then again second crossing, again it's preferably a mid-cross, not a proximal or a two distal cross, because two proximal cross will produce a neocarina. And again the OCT confirmed that crossing is you can see the crossing is mainly to a non-distal cross. Then stud dilatation with the serial balloons, followed by second kissing balloon dilatation and a final port. And in case of DK crush, the important part is the final port. The balloon should be just proximal to carina to avoid crushing of the metallic neocarina. So this is the final result, and the final OCT confirmed no malopposition or edge dissection, and vessel expansion, distal stent expansion 94%, and distal LM almost 8 millimeter squared and proximal 11 millimeter square. So LMCA bifurcation, the choice of LMCA strategy is based on lesion characteristics, and complex bifurcation is better planned with two-stent strategy, and plaque modification is the key for good PC results. Kissing balloon inflation is an essential final step, and intravascular imaging, either IVUS or OCT, is essential for optimal LMCA PCA. Thank you.
Yeah, good demonstration of DK crush with OCT. But I only take a very strong exception to your initial statement that the gold standard for left main stenting is IVUS. It is not so.
Yeah.
The gold standard for distal left main bifurcation is an OCT.
Only if it is limited to the distal LMCA. The entire LMCA's involvement, of course. If there is hostile involvement.
No, very excellently done, and I think each point has been very nicely demonstrated with good imaging. Thank you.
Thanks, sir.
Okay, I invite the next speaker. Dr. K.U. Natarajan, LMCA guided, image guided PCI. And I hope it's an OCT image.
So I'll briefly present a case of left main bifurcation PCI with the on-table unexpected change of two-stent strategy with image guidance. A 66-year-old female with class 2 angina with the TMT strongly positive, left ventricular function was good, and this is the angiogram. A lot of crowding of vessels at the bifurcation, them tapering left main, suspicious ostial disease of the circumflex, long segment disease of the LAD, and a very ugly right angle of the circumflex ostium. So these are the frozen images. So the interpretation was a distal left main disease, critical ostial and proximal disease of the proximal to mid LAD disease, right angle takeoff of a dominant circumflex with likely ostial disease with a difficult to access circumflex. So the plan was to image and confirm the left circumflex ostial involvement, and of course for stent sizing in the left main LAD. Stent the mid LAD first. If the ostium of the circumflex was diseased, to stent the circumflex from its ostium, and then in a DK crush fashion to stent from the left main to LAD with overlapping with the prior stent in the mid LAD, and do a proximal optimization and repeat IVUS for optimization. So this is the steps. I'll just quickly run through. It is very difficult to wire this LAD. Finally, we managed to get a wire into the LAD. And an IVUS interrogation was done in the LAD. As you can see here, the LAD is diseased right from the mid-distal junction all the way to the LAD ostium with a mixed plaque, a fibrocalcific plaque with less than 180 degree of calcific arc. And these were the dimensions. And these were characterized as the landing zone. The distal landing zone was about 2.5 millimeter. The proximal LAD was 3 to 3.5. And the left main was around 4.2. This was IVUS in the circumflex to the left main. And this shows significant ostial disease of the circumflex, which we originally angiographically suspected. Very tight ostial disease in the circumflex. And these were the reference areas. The circumflex was 3 in the mid segment, and the left main was around 4.5. So we did a pre-dilatation of the LAD, and also extending into the left main. We further dilated the proximal LAD with a 3 millimeter. There is a bad dissection in the LAD, as you can see, with TIMI 3 flow. Then we dilated the ostium of the circumflex. We stented the mid LAD with a 2.5 into 48 millimeter drug-eluting stent. And then we shifted our attention to stenting the circumflex. You can see slow flow due to a dissection. The patient had bradycardia. We had to put a temporary pacing wire at this point. And then we intended, as we originally planned, we wanted to do a ostial stenting of the circumflex with minimal protrusion and do a crushing with a balloon there, which is parked from the left main to the LAD, and to aim for a DK crush.
At this point, there was some inadvertent protrusion into the LMCA of the stent. We wanted to position it the ostium, but the stent came a little back into the left main. Usually when these things happen, you blame the assistant for this particular accident. And unfortunately, in this case, the primary operator was my friend, Dr. Praveen Pai, and I happened to be the assistant. Anyway, the stent protruded into the left main. So we have to change the strategy into a culotte strategy. So there was a mid-circumflex disease which was covered. Then we did a proximal optimization. We rewired the LAD, dilated it, and then took a stent from the left main into the LAD with overlap with the other stent, and did a proximal optimization, recrossing into the circumflex. And these were we had a well expanded stent in all the segments, both in the LAD all the way to the left main, as well as into the circumflex all the way into the left main. And this is the final angiographic result. So take home messages. Difficult to rewire circumflex after a LM to LAD stent due to unfavorable anatomy. A right angle takeoff of the circumflex in this case was the reason to stent the circumflex first. Upfront imaging confirmed angiographic suspicion of the left circumflex disease and helped in stent sizing, both in the LAD as well as in the circumflex. The initial planned strategy was a DK crush. The left circumflex stent slipped back inadvertently in the left main more than what was originally planned. So shift to culotte stenting strategy was an on-table plan B decision. Meticulous attention to steps of culotte stenting was highlighted in this case, and a post-stent IVUS re-interrogation confirmed ideal stent expansion in all the segments. Thank you for your kind attention.
Excellent case, Rajan. I think it is wonderful in the sense, you unanticipated complication, which actually became very handy for you to deal with. And don't blame always the assistant. It can happen spontaneously. Sometimes the patient takes a deep breath, then it pulls back. Sometimes the guide may fail you, guide may pull back, and then it happens. And the good thing was that the size of your stent which is projected in the left main was good size. If it is a smaller, it would have been difficult.
That's correct.
It was almost occupying the left main. So immediate first one would be a culotte. You can dilate and put the stent into the LAD to left main, and the result becomes excellent as in the final result. Second thing is that it need not be always DK crush. I think we are over fascinated by DK crush. It all depends upon the anatomy of the bifurcation in the left main, which chooses the technique. Any technique done perfectly will have good results. Don't go with an idea that DK crush is the one. When it is difficult, don't push for DK crush. Here, after you have placed the stent into the left main and dilatation, the anatomy altered. In fact, the circumflex which you thought rewiring will be difficult has turned out to be almost like 90 degrees.
Correct.
You could have used a tap.
That's right.
And that would have been easier. And the tap is not a bad technique. It is actually a large number in the EBC, is it not? In the EBC left main. So I think don't go with an idea that DK crush is the best one. Unless you are perfectly doing it, it will have its own problems.
Yeah.
Thank
We were a
you.
little worried about that. We had a doubt in our mind whether we'll be able to take a stent into the circumflex after the left main to LAD stent.
No, that is from the beginning.
That's
but when you works through, the anatomy also changes.
That's correct.
And that is why the technique changes.
Correct. After the balloon dilatation, you are saying, yes.
I think after if you had initially stented from LM to LAD, then probably getting into the circ would have been a little difficult.
That was our concern too. But as sir said, after the balloon dilatations, things actually evolve.
have changed.
What is difficult may not be all the time difficult.
I think,
Thank you.
And a very good message. I think that should be highlighted also. When you have this inadvertent pull in a DK crush, do not crush it. Convert it into a culotte.
That's right.
Similarly, even when in provisional, when you're planning a T with a protrusion, if you have an inverted pull, convert it immediately to a culotte. I think very important messages, and do not go and leave that metallic neocarina. Thanks, Nataraj. Okay, now I invite Dr. Joseph Cardos to speak on hitting dividers. Is Joseph not there? Okay, yeah, he's there. Okay. Pardon? He'll be last. Okay, then I'm sorry. We call Dr. Deepak Nandan to speak on LMCA intervention in an octogenarian. I think last on our. Okay, sir.
Good morning to all. This is a case of attempt of a CTO and as well as LM bifurcation in a octogenarian, that is a patient of 86 years of age in a high-risk clinical scenario. He was 85-year-old male who was diabetic, hypertensive, and history of old CVA. He had a pacemaker implanted for CHB in 2015. He is also on treatment for CKD with a baseline creatinine of 2.2. This time he presented with CAD, acute coronary syndrome, is drop positive with recurrent episodes of pulmonary edema, and he was referred to our hospital. In our hospital also, he had recurrent episodes of pulmonary edema within the hospital and became dependent on NIV. After maximizing the anti-failure treatment as well as dehydrating the patient was still continuing to have pulmonary edemas with the significant STT changes. Echo showed a global LV hypokinesia with moderate LV dysfunction and mild MR. So discussed with the bystanders regarding need for revascularization and CAG. Since he was a patriarch, half the people were wanted the patient to pass off early and half wanted an early recovery, so they consented. So it became a do and die situation for me. So this is the angiogram. The right coronary artery showing a proximal short segment CTO with bridging collaterals. The left system showing a complex bifurcation lesion involving the ostium, distal bifurcation involving the ostium of the LAD as well as LCX. LCS ostium showing around 70% stenosis, 70 to 80% stenosis. LAD showing a long segment disease till the middle AD. Very high syntax score. So thought of intervening the RCA first. So I was not confident of doing an LMCA with a closed off RCA. So I tried doing an RCA first. RCA was cannulated with a 7 French AL1 and I could wire with a fielder FC and could be opened with a 1.28 SC. And after serial dilatation, I could get a reasonable flow. After that, did a IVS evaluation. It was more of a fibrocalcific plaque and the proximal tight segment had a ruptured plaque also. So this is the pre-IVS evaluation finding. The distal landing zone had a diameter of about 3.5 with less than 40% plaque. So the distal RCA was tended with a 3 into 38 mm DES, followed by the proximal one of 3.5 into 38. So this is after the initial stenting. The next IVS run showed a proximal edge dissection, probably edge dissection or probably due to the AL1 catheter. There was a dissection in the proximal segment, which was stented with another 3.5 into 15 stent. And this was the final result of the RCA. So after doing an RCA, because a very minimal contrast has been used and patient was comfortable, went for the LMCA bifurcation also. This is the RCA post IVS finding, could get a MLA of more than 6 mm in the RCA. This is the LAD IVS evaluation. We showed extensive calcification with eruptive calcium nodule in the proximal LAD as well as circumferential calcium in the ostial LAD. Showed reverberations in the ostial LAD, so we thought that it was a thin calcium and I could break it with a NC at the maximum with a cutting balloon. So this is the LAD pre-IVS finding. The landing zone had a diameter of about 3.5 and the LM had a diameter of 4.5. LCS landing zone had a 3.5 mm and so wired both the vessels. LAD was pre-dilated with 2.75 into 12 followed by 3.25 into 12 NC and stented with 3.5 into 38 DES. Following that, the LCS was pre-dilated with 3.2 into 12 NC and stented with 3.5 into 13 regulating stent, with the stent minimally protruding into the LMCA. Then LMCA to proximal LED was stented with LED 4 into 18 drug eluting stent, and port was done with 4.5 into 12 NC. And LCX was rewired, recrossed. And the kissing balloon dilatation was done with 3.5 into 12 NC at LCX and 3.5 into 15 at LED, followed by final port with 4.5 into 12 NC. So this is the final result. So LED, we could get a MSA of 8, more than 8 in all the segments, and LCS, we could get a MLA of more than 6. So patient tolerated the procedure well, even though he was on NIV and Lasix infusion. We could limit the VC peak to 250 ml, and the discharge creatinine went up to 3.6. He's on follow-up, and there was no further episodes of LV. LV function improved to mild LV, and now the creatinine is 1.6. Thank you.
It was an excellent case, Dr. Deepak. You haven't, it was in the left main, it was not a classical DK crash. You have just put the stent up to the, near to the ostium, and it.
Yeah, I wanted to do a DK crash, but the patient was unstable, so I made it a single crash actually.
Okay, fine.
The complexity was because of the lot of calcium there?
Yes.
Yeah. So you have calcified nodule as well as 360-degree circumferential calcium. How did you manage the calcium? Balloon alone. It's balloon strategy.
With NC, I could break it actually.
NC balloon, yeah. That is one good demonstration that eruptive nodules are compressible with the balloon. And not only that, the eruptive nodule is confined to a small sector. The rest of the sector of the vessel were okay. In such situations, you don't have to go for with the complex devices like a rotational atherectomy or orbital. Balloon will be able to crush it down, and then you can manage it. That's one good thing which you have shown. Thank you.
Yes, thank you. Now I invite Dr. C.D. Ramakrishnan. Where is he? Yeah, Onudande. Last, other heating devices. So, Dr. Ramakrishnan is going to show us LM bifurcation with IVL.
Good morning, all of you. Respected chairpersons, dear friends. I am presenting the case of LMCA bifurcation lesion. It was not true LMCA bifurcation lesion. There was tight critical lesion in the ostial LAD with some plaque in the distal LM, and LCX ostium was normal. And actually, patient initially I did some culprit lesion angioplasty, but patient came back with ISR, then with stent under expansion the ostial LAD. And second procedure, after 5 months, LM bifurcation PCI was done with IVL therapy. I am sure that there will be a lot of criticism and difference of opinion, and Bahulan sir and Roni sir may not agree with this case, and I am already taking the, I am taking the anticipatory bail now itself.
Not at all.
Don't proceed like that. We are with you. Both of us are with you.
Okay, sir. Okay, thank you. Patient was 72-year-old elderly lady. She was hypertensive and diabetic. Severe angina, function class 3-4. Normal LV function and normal renal function. CAG TVD, calcified vessels, ideal candidate for CABG, insisted for CABG, but not at all willing. Both patient as well as bystander. Actually, I had a lot of issues with these patient relatives because I insisted again and again. I was not keen for angioplasty for this patient, but finally planned for culprit lesion angioplasty just to relieve the angina.
Commissioner, just a minute.
This is that.
Sorry to interrupt. So this again is similar to the last session. Bahulan sir will be discussing. There will be at least 18 minutes, including presentation.
18 minutes?
Pausing in between.
I've already taken anticipatory bail. Okay, so this is angio. There is ostial LAD, very tight critical lesion, almost 99%, and some calcium containing lesion. Distal LM, some plaque. Ostial L6 looking normal. Mid and distal LAD normal. And RCA diffuse lesion from proximal to distal LAD. This is for CABG. I think all of us agree with that. The patient should go for CABG. but elderly lady, but no other major comorbid issues. So this is the case, I think. So, okay. So then I decided to culprit angioplasty of the distal ostial LAD. San French EBU, initially field Repsi, usual floppy wire, but wire didn't go. A lot of difficulty in wiring that lesion. And I took field XT, it was wired with field XT. So I started facing the difficulty even from the beginning. So wiring was with field XT. Then is 2O balloon, non-compliant, inflated, but there was some lesion was not yielding. Again, I have done the I was at that point in time. I'm very sorry that I couldn't retrieve that image because initially case was not interesting. When the patient came back with ISR, it became interesting. So I couldn't take that. But actually, I was showed.
Rameshan, did you do the IVAS before,
Yes, sir, actually,
before this PCI?
Yeah, before, during at this step, I have done.
You had the IVAS?
Yes, after dilating with 2O balloon, 2 pump, then I did the IVAS.
Yeah,
but actually, I was showed fibrocalcific lesion, but there is no extent of calcium was that much. It was a fibrocalcific lesion, but calcium was not very dense.
At the ostium LED.
Ostium.
Okay.
So that I took.
Another thing is that one more question. That's what about the distal LED part LED? Distal LED angiogram. Can you show the angiogram?
Okay. Distal LED is normal.
So yeah. So
distal and middle.
Distal LED is actually from the middle to distal LED, that graftable portion is not very good from this angiography. And you have an ostial LED lesion and a diffuse RCA lesion. So I think you don't have to be that much apologetic about doing a PCI in this patient. Right?
Okay, then the distal circumflex actually some lesion was
in fact,
there.
if you give to the surgeon and surgeon comes back and tell you that LED is not graftable, then it becomes really a bad situation.
Yeah.
I think what you have done is right.
Okay, thank you, sir.
Now, we should feel that interventionalists are doing the right thing, because we have discussed. And then yes.
Okay. Distal circumflex, there was some bifurcation, some lesion was there.
Yeah. Now the second question is that you have IVAS, and the IVAS has shown some calcification, but it is not heavy calcium.
No. It was fibrous.
Neither no nodule was there.
No, sir.
Okay, fine.
So then, so I took cutting balloon 3 into 10 Wolverine, and I inflated to 12 to 14 atmosphere pressure, and as lesion was yielded actually, I thought that the lesion preparation was enough. So I took 3.5 into 10 because already took a lot of time. So I thought just do the culprit lesion, just because I have told just to relieve the angina only. So 3.5 18 drug-eluting stent was taken, positioned in the ostium, and so it inflated. But some stent under expansion in that stent boost is showing that some stent under expansion. So 3.5 into 10 non-compliant and inflated up to 20 to 24 atmospheric pressure, and reasonably good result. But some stent expansion is there. So I thought she may come back with some symptoms again. So that time I stopped, and I after follow up that patient.
Yeah. Yes. I think the vessel was is easily 3.5 millimeter vessel. You have used a 3 millimeter cutting balloon. Yes. What pressure did you go with that? Because it's a undersized cutting balloon, one size down. So it's not 1-to-1. Yeah. So what size, pressures you have gone?
Maximum up to 14.
14 atmospheres you have given. And followed by the cutting balloon, did you use a 1-to-1 high pressure balloon to see that it is dilatable before you push in the stent?
Not so.
I think that's one step. One should always do that. After cutting balloon, don't presume that the things are taken care of. Do with a 1-to-1 balloon and inflate it and see that it is inflatable nicely, at least in 2 views.
Yes.
So that you are sure that you can go with the stent. And then of course you have gone with the stent, and it seems to be really under expanded, and you said you had the IVAS was not gone from your lab at that time. Did you do the IVAS and then find out how much is the MSA?
No, sir. After that, I didn't do that. At this point of time, I didn't do the IVAS.
IVAS.
I actually have done after the.
No, this is stent
No, no.
deployment.
That point, I stopped at that
You
point.
stopped at that. You didn't try to
I
look at
thought that
what is the MSc.
just to relieve the angina, that may be enough, but.
But you accepted that under expanded stent at that point in time.
Yes.
And come what may, we will see what happens
Yes,
later.
sir, yes.
Okay. Thank you.
Yes.
No, see, Dr. Ramakrishna, I think there was a significant distal LM disease. You should have stented into the right up to the LM ostium. LM is rather short. And anyway, you have an IVAS. The circ lesion, that ostial lesion doesn't appear very significant. Distal circ, okay. There is a lesion again, sort of 60, 70 like thing. So I think you should have evaluated that circ lesion better. And you should have stented from LAD to LM ostium. And anyway, IVAS is also there. Yes. And you could have optimized. This even angiography doesn't look all that great.
Yeah, could have gone for a dedicated bifurcation PC at the first, but because during the procedure, because it took a lot of time to wiring and all, then I thought just.
Hello. So now that you find that there is a significant plaque shift to the circumflex side after the LAD stent,
yes.
Whether you would have paused at this point or you would have done something else or something differently?
Now, the plaque shift has happened into the circumflex and it is going to be a problem. And we have to take care of that in the first instance itself rather than leaving it. Either the stent stops at that. If the stent is, here imaging is very important. And if you find that if the stent is protruding already into the LAD, sometimes it happens. Then the placing across that stent is another stent across, and then correcting the circumflex is difficult.
So what would you predict in the follow-up? You expect a significant narrowing, that is progression of the ostial circumflex lesion, or an ISR, or both?
Both. It could be both.
And I think the most important thing in this is, of course, there are reasons why he has done this, but the problem here is going to be stent thrombosis. When you have a MSA that is so small in the ostium of the LAD this is not a carinal shift, this is a plaque shift into the circumflex, and you already said that there was a circumflex lesion. I would be more worried about him coming with an MI.
It's a very interesting case. There's a significant calcified ostial lesion LAD. In angio, we could see a severe calcification in the proximal circumflex that were not visible in your IVAS. And there's a short left main. And we should see a space for port in case there is a compromise in circumflex. So we would have prepared, you probably got some difficulty in preparing that ostial LAD lesion.
Yeah, definitely, yeah.
And did you analyze what is the reason? Is it because of the calcium or any?
It's actually mainly fibrotic, but some fibrocalcific. But the extent of the calcium was too much, not too much.
So what you are expecting here is the ostial critical. Now your circumflex ostium is also critically stenosed. Left main is compromised because of the short stent. These are two things now you have to tackle. How you are going to do, we'll see.
It's very important, at this point, whether we are going to correct it or leave it. If we are going to correct it, how are we going to correct it? That is the question. And the narrowing of the circumflex is very important at this stage.
Sir, I think my question is, sir, actually, did you remove all the wires and finish the case?
Huh?
You finished or you are going to do?
At this time, but I finished. Then patient came back again and restarted the procedure.
I was thinking he is actually why to remove the wire. That's what my question.
No.
Now there is no wire.
No, it's finished.
Pradhavan, he stopped at this stage, accepted that result.
So in such a case,
Sir, actually in the audience, actually anyway, Ramakrishnan did, maybe it is very correct, but I'm telling, I will not do this. Actually, basically when you do a osteoproximal part of the LAD is not opened up very well, and even if the cutting balloon is not done the work, as sir told, you have to take a 1:1 balloon and dilate at high pressure. If that is not working, you have to take the next level of cutting balloon and dilate very well. Because this, you cannot just leave it. And you have to keep a wire into the circumflex, as Ronnie told. Already there is a plaque shift, and then it can create a disaster situation. And if it is closed, you may not be able to take the wire inside. That will be my tragedy part.
Now the question is that what are we going to do? If you are going to leave it or do it something? No.
Suppose if such a scenario, in such a scenario for future, is it possible that we convert it into a QLO with using LM to LCX and then redo the stuff LM bifurcation again, so that you treat the circ and get this small amount of barrel in the LM used in as a QLO?
It all depends upon how much stent is protruding into the left main.
Yeah.
The LED stent, how much is protruding into the left main?
It was an LM to LED stent, sir. At least
No. It's an ostial LED.
Only ostial.
5
It is not
5
LM.
mm looks protruded.
Only
5 mm
ostial.
looks protruded.
No,
See,
ostial.
there are three possibilities. One possibility is that
You'll have
he's
to image it.
very right. It is dot on the osteo and nothing is coming into that. That is good. In which case we can extend. We can extend from the left main to the left and cross over into the circumflex and open up. That is one. Second thing is that the stent can protrude into the left main across the circumflex well. Right? That is one option. Or it can extend only a small, one strut. These are the two options.
The small amount
when it is extending very well into the left main, then you can culotte it.
Otherwise, you
if it is extending only a small strut, you crush it to the opposite side and then do it. These are the three possibilities.
The stent is not come up now, because even after post dilatation, the stent has not come up. So the stent has not expanded. So now we are going and putting another stent into that one. What will you do with this first stent?
That we have to use, as Dr. Padavan said, we should use other devices to expand it.
Already the stent is there. Stent is under expanded. You don't have to do cutting balloon. Whether you have stent ablation or something like that. Stent ablation or something like that.
Even stent, which is not expanded, it may be due to the peristent calcium, which is not tackled. Peristent calcium can be tackled even after stent has been placed.
Yes.
I think
there are devices.
It should not crush that LED stent, because there is an undilatable, unresistant, residual stenosis of the ostium of the lady. We should not crush it now. Then you will be have difficulty in crossing and doing any type of procedures.
After preparing the left main, after dilating the circumflex, then you, in order to treat the circumflex, that is the option.
Sir, his difficulty is not that. His difficulty is that lesion is not dilatable. It's not expanding. What you are going to do?
Sure.
Yeah, realize that. This.
I think the IVL would be a good option for that.
It's a second.
No, at this time itself, sometimes an expanded stent, because of the calcium, which was not broken prior to stent placement, can be taken care of. Super high pressure balloons. Opium balloon could be used and then it expands. So I think it's not a given up thing altogether.
Yeah, actually that size of the open was not.
Anyway, you are so bold enough that you left it. Let us see what happens.
Anyway, regarding the open, that size of open was not available in the shelf. That. Anyway, patient.
We'll proceed.
Shall I continue?
Let's proceed.
So patient actually after the 3-4 months, she was symptom free. So that kind of severe angina was relieved. But she came back after the 5 months. It was initial first procedure done in January. She came back in June again with severe symptoms, again function class 3. That time, the angio showed there is tight ISR in ostial LAD. And so this time I again advise CABG because this now at this point of time there is ISR is there and TVD is there, calcium, everything is there. But again she was not willing. So I told you may require IVL because there is stent under expansion, some calcium. So IVL, it is costing around 2 lakhs. So finally they agreed for that. So I proceeded with, this time I did the IVS pullback. There was a lot of, there is stent under expansion was there, maloposition in the ostial LAD. So that I took IVL, it's a 3.5 mm 12 IVL. So initially in the stent under expanded part.
Please stop before you. You have the IVS done. You have found that the under expanded stent. What else you have found? What is the reason for under expansion? That is one of the reasons for IVS.
Initially, already under expansion was initial.
No, but then we should find out the reason for under expansion by doing IVAS. Then only we will have the options to correct it.
Yes, sir.
Do you agree with me?
But I was, I think, was.
But then the calcium, the stent being there,
Yeah.
the calcium,
Calcium?
underneath is very difficult to see.
So
We can see it. Peristent calcium, OCT may be very good, but IVAS also peristent calcium could be made out.
I think you used a 20 megahertz here because
Yes,
it
sir,
looks
that
like a
old,
20 megahertz. And I also was not able to appreciate calcium outside on 20 megahertz.
I was mentioning our old.
I mean, IVL is fair enough. In
Yes.
this
Then actually, because already IVL cost and additional OCT cost, financially in our government setup, it will be difficult. That's fine.
Perfect.
Anyway, then IVL, they agreed for IVL. So IVL, I took 10 pulse, 20 pulse in the under expanded part. Then
What was the size of the IVL?
3.5 into 12, sir.
3.5.
3.5.
Yeah.
So there was surprisingly it was expanded. Then there is, to my surprise, it yielded very well. Then again 20 pulse pulled back in the left main because there are a lot of calcium in the left main. Pulled back again further 20 pulse. Then shuck shoot after that. Then already there are 80 pulse. We are giving 2 lakhs. Then I thought I'll do IVL in circum because only 40 pulse they won't give the discount. So I thought I will. I again for 20 pulse in the distal circumflex again. So all 80 pulse finished. Okay, then. So that is then distal circumflex lesion was dilated the two.
Otherwise, also you should finish all the maximum pulses to be given to the lesion, even if they are giving you free.
Yeah, that's why. In and around left main, I finished all the pulses. Okay, then check shoot after that. So again, 3 into 23 drug elution in the distal circumflex. And this time, which strategy we should follow? Because already some one or two stud may be in LEM, but I did only hostel stenting. So I thought I just, anyway, I wired outside the stud. So I just took 3.33 drug eluting to the LM to LM ostium to circumflex overlapping. And position the LM ostium, inflated.
Ramashna, can I pause?
Okay, sir.
Come in, sir. Because now we have a wire in the LAD and we are stenting from the left vein to the circumflex and we have a stent in the, which is now expanded.
Yeah. What was the reason for stenting that left circumflex right now?
That lesion is there, sir.
No, let me see that
Okay,
picture.
circumflex actually distal.
Now that now the picture.
The distal.
This was the earlier picture.
Yeah, actually it's a severe PV.
After 5 months, when the patient came back. Let us see that. This is a circumflex. This is after dilatation or before dilatation?
This is after IVL. After IVL.
Okay.
After IVL, distal IVL, some discrete lesion.
Okay. Yeah.
Anyway, this time I decided for complete revascularization. Because I have done incomplete first. So yeah, complete revascularization.
Yeah.
So that will benefit the patient.
Yes.
So
now the Ash's question is relevant here. Now you are placing a stent from left main to LAD, and you have another stent from LAD to left main. How much that is coming into the left main?
Left main whole left from ostium I am stenting.
Only up to the ostium.
After the ostium, because only
up to
short
the
left main.
That is
And only thing, so already one stent is there, which is under expanded. I dilate the IVL, but which strategy we follow? Because the only thing, this case, I think we should just crush 1 or 2 sets, maybe reverse mini nano crush, some we can call it as, because otherwise no other, because one more step, putting one more stent in osteal LAD, I'm not, because.
So actually he is presuming that it is projecting a little bit
into the left main.
Little bit into the left main, and he is going to crush it.
Yeah.
Yes.
But the wire is still there.
We can call it as crush.
Crush. Wire is there.
Wire is outside the stud.
Wire is out.
Outside that in LED. Easily I put wire, easily, there is no issue. But not cool out.
Crushing with the wire.
Wire is in the LAD.
You have the wire in the LED,
LED also wire.
and you are placing the stent from left main to circumflex and crushing, and then you keep the wire.
No, sir. Then look out. Then I did the kissing dilatation.
Sir was saying better to take the wire out.
Yes.
Before crushing.
So he has done it. He has done it. Okay.
No, he has not done it.
So then 4 into 10 balloon for pot in left main. Then the check shoot after the pot. Then I did kissing balloon dilatation in the distal LM, 3.5 into 10 non-compliant balloon. Sequential after that kissing dilatation. So again repot with the 4 into 10 balloon. So final check shoot. This is the final check shoot. So in Arewa caudal and LA caudal. So this is just fluoro showing two stents. And again, I was pulled back again. This time stent is very well expanded. MSA stent well expanded in left main. MSA is around 12.8 in left main and circumflex is 7.8. So
LED? LED.
LED also I have done. It was MSA was good. LED. This. No, LED also I have done the pull back. It was only two. This is circumflex and left main.
Okay. Okay.
Okay, can you go?
So anyway, you have done pullback from LED as
LED
well as
also
to
I
the
have done.
LM and looked at the osteum, the circumflex, LED, polygon of confluence and the LM. All are okay?
Yeah, okay with the acceptable MSA acceptable. So then
Yes,
follow
Ashish.
up the PCI.
Yes, Ashish.
How would you have done it differently the second?
This case.
Yes. The second part of it, not the first part of
First
it.
part,
Now the
second
second part of it, would you have done it differently? And if so, how?
No, I think I told you that it depends upon the first stent, how much it is extending into the left main. If it is extending across the circumflex, down into the left main, you can do a culotte. And culotte means the wire has to go through the stent struts. And you have to ensure that it has gone through that. Otherwise, you will make catastrophe. So I always do an IVS. OCT also is good.
Suppose you take the
Because
third scenario wherein it is only osteal, pakka osteal LED.
If it is only pakka ostium in the LED, I closely look at how it is covering the ostium of the circumflex. If it is a strut, one strut into the dorsal aspect, I am happy because it is covering that when I crush it, right? Then you can make a crush into that and then make a kissing balloon infusion.
Exactly.
But
So if it is true osteal, how can you crush it? If it is true osteal,
no, if it is simply the ostium, then you can you mean how do we treat the circumflex?
How do you tackle that? Because if you end up if
it is into the circumflex, you can make
no
it,
issue. But if it is true osteal without any protrusion to the left main,
and then there is a circumflex compromise
Yes.
into that,
yes.
then I think one possibility is to extend into the left main and then tackle the circumflex. That would be a very nice option.
See, the problem here is he has done an IVL to the circumflex. He has torn the circumflex. So he has dissected and torn it. And as he says, I mean, you have dissected it. Yes, you dissected it.
Yeah.
I mean, the method of angioplasty is tearing. No. I think what he's done is right because he has got a stent right up to the osteal LED and he has gone and dissected or torn or whatever the circumflex to the left main. So you stent the circumflex to the left main, convert it into crush.
That
He
is
has
what
not
is-
on the IVS.
No, but that ostium, actually, my question is after the IVF, he should have done one more IVS to understand.
No,
ostium
he
is
should
well
have done
covered.
OCT because only that will tell you whether the strut has reached the ostium.
Okay,
This will
no.
not tell you. You will not know.
Now, why not do an ideal the way Dr. Ramakrishnan has done? Stent from the ostium of the circumflex into the circumflex with minimal protrusion, and then do it like a DK crush or mini crush from the final stent should be from the left main to the LA.
Yes.
And then kissing and the pot.
Fair enough. But then what is the advantage of that over what he has done?
Might have missed.
One
No,
No,
Natarajan, that's
I
why I
don't
said,
agree with that. You got to
I have mentioned that. Make sure that, it's not like square. From the imaging we can make.
We can make
I have
out.
done it. That means the circumflex one strut is onto the dorsum coverage. That helps you. If that is not coverage, if it is exactly like that, only way is to stent it
Yeah,
up.
and then instead of 2 stents, we're using only 1 stent.
And often, this is in practical, it is not stopping short at that. Most of the time, it will be getting into the left main and across the circumflex and variability. If it is halfway through the circumflex, you have still more difficulty. Because then if you extend from left main to LAD, you are having 2 strut layer across the circumflex. That is more damages, and then Ronnie's method of the new tissue growth.
Yes,
It will be more, it will be more into that.
I'm fully with you. I think what you done is right.
And I fully agree with Ronnie. I fully agree, Ronnie, sir, because OCT is ideal for this case, not IVL.
No, that we can take up in the evening. There is plenty of time.
We are running short of time. So we are running short of time.
Can
We
I-
need
can I make a point?
Final
Ashish?
comments from Bowlen, sir. 1 minute, sir.
Sir,
1 minute.
one
For
last
you,
line.
sir.
On the case.
Sir, can I-
I think final comments from my side is that left main and bifurcation intervention.
Here, Ramakrishna has done just a POBA. He has done an IVL, but effectively he has just done a POBA to the ISR in the LAD. So when you were doing the final kissing balloon, you could have done with a DEB. You used a DEB for the final kissing balloon for the LAD stent. And probably that would have finished the case because he has already done the IVS pullback and probably he has shown that there are stent struts extending up to the left main.
Yes.
So probably a final depth to the LAD stent and a regular balloon for the final kissing balloon would have done the job for them.
Yeah,
Yeah, I agree with that, but additional cost will be.
No, sir.
Yeah,
Final comments.
Sir,
on the
last,
case and
one
everything.
last
Yeah, I
slide.
think it was a wonderful session. We had a very good discussions. And I'm so happy that left main, however it is complex, is being taken up by more and more interventionalists. And that too is being done more correctly. This is only because of the advent of imaging, whether it is OCT or IVUS. It is only because of the understanding of the anatomy by the imaging. And finally, understanding what we have done, finally optimizing the result. I think that is the one. So we should. Big pardon? Yeah. Yeah. That is.
No, I have done that.
definitely
That's I'm
okay.
explaining.
So I think.
RCA I have done.
Yes.
One more, 2 slides.
Yes,
Last one slide.
Yeah.
So RCA was also done. Then 5 months she is symptom free. Now we have discussed everything. Just take home message. Sir has given all the messages. So treating calcified TBD with LM lesion in patients not willing for seizure is always challenging. We all know that. Lesion preparation is perfect, should be perfect prior to stenting. In this case, it was not, it was suboptimal. IVL is the option, I think, because stent under expansion is IVL, and now I think Deepak is having laser for that. Then, but IVL we can consider for stent under expansion stent with ISR. LM bifurcation strategy in patients already undergone LAD ostial stenting. Which strategy you follow? We have discussed. If Sara has discussed everything, and stent optimization should be done with imaging. Thank you.
Thank you. The all is well. The patient and the relatives are with Ramakrishna. That is great.
Yeah. Yeah.
Thank you, Ramakrishna.
I think we'll invite Dr. Deepak Nandan for the last talk of the session. No?
Joseph Cardos.
Sorry. Joseph Cardos. Yeah. Deepak is over. Yeah. He's going to hit dividers. I think that's Neo Carina. Ramakrishna
A very good morning to all of you. After that brainstorming presentation, now a little more mild presentation, I've titled this presentation Hitting Dividers because during the course of this case, we kept hitting roadblocks. That's the only reason why I unpretentiously termed the presentation Hitting Dividers. Okay, so my patient is not seeing it there.
That is also hit a divider.
My patient was a 90-year-old nun. She came with history of recurrent chest pain going on for about 1 week. She was initially treated elsewhere, and as expected, she was treated conservatively. And she came to a casualty with worsening angina. ECG showed T inversion in anterior leads. Echo showed RWMA with a mild LV dysfunction and moderate MR. So we were also not very keen to go interventionally. So we kept her in the CCU 2 days on NTG, Nicoran, etc. But in view of unabating symptoms, and she was taken up for CAG. And her diagnostic angio showed distal LM about 60% stenosis with critical lesion in the proximal LAD extending from the ostial LAD. And there was something like a borderline ostial circumflex lesion. So these are the other diagnostic images. There was a little bit of a aneurysmal segment in the LAD, and LAD was critically stenosed. The other views did not show too much of lesion in the ostial circumflex. So these were her diagnostic angio images. So after this, the angio was done on Saturday. Obviously, we discussed about CABG, but age and other barriers were there. So we thought of arranging for IVUS and cutting balloon. There was a bit of calcium in the angio. So we thought of planning the case with IVUS, cutting balloon, etc. However, the very next day, night, the patient became unstable with hypotension. Earlier, the BP vitals were quite stable, but now she developed hypotension, worsening angina, and she was totally restless. And the bystanders seeing her, and now they were like willing for anything. So we took her up for plasty. Wanted to go with a provisional standing strategy, the KISS principle, to keep it simple, swift, and safe. So now we went with the 7 French EBU. The lesion looked almost the same, but probably I think now the proximal LAD was like a near total occlusion. So wanted to just do a LM to LAD and come out quickly. So we took a 3 into 15 NC balloon and started dilating the LAD. There was a bit of calcium, but not so much, I thought. So started off with the pre-dilatation. We just about pre-dilated, and then the very next moment, a patient, became very bad. There was, like you can see, there was severe flow compromise in the circumflex. And then she developed brady, hypotension. We had to resort to short CPR. Then, inotropes had to be hiked up. Overall, the situation was a little messy. Here again, the spider view shows that the heart is almost not contracting. She was quite unstable now. BP was also dropping. And so obviously I had to bail her out. So I couldn't think of any complicated standing strategy. So I went with a SKS, took a 3.524 Osero in the LAD and 2.7522 in the circumflex, and then come what may, dilated both together. So SKS stenting was done. After this, miraculously, patient the hemodynamics picked up and patient looked little better. So now wanted to do a kissing balloon dilatation. Passed a balloon into the NC balloon into the LAD. It went smoothly. Unfortunately, I just couldn't negotiate even a small N balloon into the circumflex. It was just not going across. So then we started with the provisional, went into a SKS, and then there was no option left. So I had to I took out the circumflex wire and then did a crush, like a pot crush. We crushed the circumflex stent. And after that, it was a little more easier to pass balloons. First, we went with a 1.510 semi and then a 2.7510 NC into the circumflex. Then after that, did a kissing balloon inflation, and the final result then did a pot, and after that looked quite decent. Thank you.
Yeah, excellent, Joseph. I think a very good bailout. And I think it's a fitting case to end the left main session with. Because when in an emergency, like what you have said, when the patient is crashing and you got a left main, you got a circumflex LAD lesion, just do the SKS and come out. And the only thing I think is once you do an SKS or a V with a little protrusion, don't put one balloon. Always put 2 New York balloons inside. Because if you put one balloon inside, it is very, very difficult for you to take the second balloon inside. And in this situation, you did bailed it out even better by crushing it. And I think it's fantastic.
Thank you.
Yeah, I also agree. It is excellent saving of the patient. Good. As case this problem happens, and then you have recognized that immediately and went in for crushing and then getting her out. Good.
So I
think we will stop this session. It was fantastic, and all presenters were done excellent cases. Thank you all.
Thank you, Ananda, dear most chairpersons and speakers. Now we are moving on to the official inaugural ceremony of ICCK Annual Conference 2023. Post-capture ISR interventions. Requesting the chairpersons, Dr. Anand Marthandapillai, Dr. Bino Benjamin, Dr. Mangalanandan, and Dr. Rajalakshmi to the joint to dais. And please be seated.
Yeah, good morning all. We now go into the another interesting session on post-CABG and ISR interventions. I call upon Dr. Joe Joseph for his talk on recurrent angina in patent grafts. Does physiology help? Shall we? Okay. I think we move on to the next talk from Dr. Jitu Sam on refractory angina.
Good afternoon to all. I'll be presenting a case of it's a 62-year-old male who, in a known case of hypertension and diabetes, who initially had exertional angina, and it was an LM plus triple vessel disease for which he underwent CABG with 3 SVG grafts, one to distal LAD, one to proximal major OM, and another to proximal PD and PLV. It was a Y graft. It was done in April of 2023. However, he presented again with an NSTEMI, drop elevation and chest pain, recurrent chest pain, just 3 months after the procedure. So initially he was started on heparin and stabilized, and he was taken up for an angiogram. The native angiogram shows there is a tight stenosis in the distal LMCA with the major OM is occluded. Okay, you can see the disease, which is calcific, and it is extending into the proximal and up to the mid LAD, about 90% stenosis. And LCX distal has diffuse disease, and the major OM is near ostially occluded. On the right side, native vessel, the RCA is diffusely diseased from proximal to distal RCA. And even the PDA PLV can be seen filling. So we expected the graft failure on both sides. So this was the SVG to RCA, which was occluded. And another SVG to the OM, you can see there is a tight ostial stenosis, as well as there is another 90% stenosis at the anastomotic site. And we couldn't cannulate the LAD SVG, but root injection showed a possible occlusion of that also. So it was again a left main with a graft failure of both. So initially we advised redo CABG. The patient was in ICU because of recurrent angina. And the surgeons had explained to them high mortality because of earlier redo surgery, and they were not willing. But initially, during medical stabilization, the patient was having recurring angina and occasional episodes of pulmonary edema, and we had to do something. So since the LMLAD was looking like doable, we thought we will proceed with PCI to the grafts also if possible. And this was the, we kept a TPI just for, means we were doing an LM intervention and there was not much support on either side. This was, it was engaged with a 7 French EBU 3.5 catheter, and LAD was wired using a pilot wire. It was pre-dilated with a 212 non-compliant balloon and 2.5 15 non-compliant balloon serially. And initially, a stent 3 into 2.29 was deployed in the mid to distal LAD, early distal LAD. And another stent from proximal LM to in an overlapping fashion was deployed, just 3.5 into 37 drug-eluting stent. Then we proceeded to angioplasty of the OM graft. It was engaged with a 6 French JR catheter, 3.5 JR catheter, and it was wired with a pilot wire. Pre-dilated with initially 1.2 into 8 non-compliant and then 2 into 10 semi-compliant balloons. And initially stent was placed at the anastomotic site, which was 2.25 into 9 DES. And another stent to the proximal near, it was a 2.5 into 44 DES, which was to the ostium and proximal, slightly protruding into the aorta. And it was, the balloon was pulled back and the ostium was flared. Another 2.75 into 12 NC balloon was used to post-dilate the proximal stent. So both native angioplasty and SVG angioplasty were done, and these were the stents which were used. Because already the contrast load was much high, the RC was not dealt at that position. But I don't think the patient will be willing for any, because he is free of angina at present.
First of all, actually, it must be aggressive atherosclerosis.
Yes, yes.
Vein grafts are known to have short life, but then this fast is unusual.
Yeah.
And actually, Lima was not used for this patient.
No, madam. Actually, we asked the surgeon. They told there was some anatomical difficulty or something, and we can't question the surgeons in our center. So,
and was the patient on medications, or sometimes they think?
No. They were on regular medications. Antiplatelets and all were strictly followed. Yeah.
And for the actually in the LAD, you have put 2 stents or?
Yes, ma'am.
Just an
LAD, it was initially at 28 millimeter, and LM to LAD another 37 in an overlapping fashion. That is 3.5 and 3 stents.
Okay. And the circumflex native vessel could not be attempted?
It was actually OM ostial occlusion, madam. And we thought it will be a long lesion, so we proceeded with the graft.
No, interventions in SVG again.
It is
Because he has
more.
problems with all the graft.
Yeah, yes, ma'am. It's, likely to be risky.
Are you planning for intervening the native RCA later?
So it is a very diffuse and calcific disease, means vessel. If symptoms arises and if required, yes. Native RCA, yes.
It's likely to have angina.
Yeah. Yes.
Because the RCA territory is, likely to be ischemic.
Yeah, yes.
Either you can reopen that clotted SVG or
SVG is osteally occluded. We will more prefer for the native vessel. Yes, sir. Yes, sir. Definitely. Yes, sir.
You can use calcium modification and that kind of gadgets.
Yes.
Thoughts about need for a distal filter while intervening on the SVG graft?
Pardon?
Thoughts about using a distal filter.
Yeah, because of financial constraints and also there was no obvious thrombus, so we took chances. It was
Actually,
not
we had
available
a,
also.
Similar case in which within 3 months the SVG graft to one of my patient
Okay.
to diagonal.
Okay, ma'am.
He had actually lima to LAD and the diagonal surgeon had used an SVG graft.
Okay.
And only that got in the distal end, near the distal end. So I discussed with her and she was telling better attempt the native vessel.
Okay.
And I did on native vessel. But surgeon was telling that it is actually an inflammatory process if it is near the anastomotic sites.
Okay.
So
This
it
was
may
also
be
near the
fibrosis.
anastomosis. Yeah.
Inflammation followed by fibrosis.
Yeah.
So better not attempt on the SVG.
Okay,
And she was advising me to do on the native vessel, which actually could be done in that case.
Okay.
Okay.
Thank you.
Thank you.
Thank you.
Next, let me call upon Dr. Karanadas, venous graft intervention with distal protection.
Good afternoon, respected chairperson, senior members, and friends. This patient was a 67-year-old male diabetic, came to us with recurrent angina for last 10 days, and he was having recurrent pain despite optimal medical therapy. He had undergone CABG 8 years back with lima to LAD and SVG to OM. We did an angiogram which showed a patent lima with the SVG graft having 80% stenosis. LAD and LCX were having total occlusion. RCA was diffuse, small caliber with good flow. So this is the angio of the SVG graft showing a discrete tight stenosis in the middle. We decided for PCI to SVG with a embolic protection device. The thought process was like this. He was having recurrent angina, so he needs intervention. Redo CABG, not required in this case as the lima is patent and it is fraught with many complications. Native vessel disease is the one to be attempted, but it was very complex and difficult. SVG lesion seemed not very complex, and we considered an embolic protection device because there was a good margin from the lesion as well as from the anastomotic site. Ephemeral access was taken with a 7 French sheath. We had to try multiple catheters. Even though initially we could do a diagnostic with a JR, we could not cannulate with JR 3.5 multipurpose catheter AL2, and finally a 6 French Icck left cannulated the SVG graft. And this is the angio. A 0.014 run-through wire was passed. And the distal protection device we chose was a 3-spider FX. That is the spider being passed through the guiding catheter into the SVG graft. You can see the markers. Passed it well beyond the lesion. and deployed the spider there. Slightly difficult to see the spider deployed. It looks like this. And outside the body, we have demonstrated how a spider looks when it is deployed. Actually, it has got a green tube as well as a blue tube. You must have seen that. The deployment is through the green one. And the outer sheath is being pulled out of the spider, which is kept in the distal part of the SVG graft. And a 3x23 drug-eluting stent was taken. No pre-dilatation was done. If possible, it's better not to pre-dilate a venous graft, as this leads to distal embolization. And the stent was deployed at 12 atmosphere pressure. It is recommended that you don't go for very high pressures during stent deployment in venous grafts. The next step is to retrieve the spider, and this was where we thought we might have some problems. The spider may get hit on the distal part of the stent and difficult to take out. But we could retrieve the spider, and that is how a spider is being pulled back into the blue sheath. The spider was taken off, and that is the final angiogram. This was done around 8 months back, and the patient is doing fine. So the take-home message from this is, if you look at all the literature, they say don't go for SVG interventions. You try to prevent the graft loss by meticulous, proper treatment with statins and antiplatelets. If the lemma has not been used for some reason or other, like in the previous case, always consider a re-CABG, especially if there are multiple occlusions. Do PCI to the native vessel rather than to the graft if feasible. That is the best thing. Embolic protection devices had a class 1 status in the previous recommendations, but now in the latest ACCHA SKY recommendation of 2021, they have a class 2A recommendation. You can use them if feasible, not in all cases. You should have a good margin from the lesion site, 5 centimeter, and from the anastomotic site. Otherwise, you may get stuck. This spider may get stuck in the distal lesion. Thank you.
Excellent demonstration of embolic protection device. So was it easy to toss that embolic, even passing the embolic protection before a pre-dilatation, sometimes that itself can throw some embolism?
Always there is a risk of distal embolization when we are attempting an SVG graft. But here it went very easily. There was another case where we could not pass. So we pre-dilated and then stented without any protection device.
Did you get something in the filter?
Nothing. Nothing.
And
Probably it was not a very degenerated graft. It was a very discrete lesion.
Looks so. And you didn't post-dilate this?
No. That's also not advised. If the stent is well dilated, better don't go for post-dilatation, high pressure dilatation. As far as possible, do a direct stenting, come back.
Dr. Kanadas nicely demonstrated case. One doubt, didn't you take that sheath back into the distal to the stent before the...
Yes. That blue sheath we have to take distally, take the spider in, and it is advised that you don't take the whole thing in. Leave a little behind for if there is some material inside. Otherwise, it may get squeezed and go distally. So not take fully.
That's why you are expecting that it may hit the stent edge.
Even then, sometimes because of the angulation, that spider may get hit on the stent edge.
Okay.
That is described. Then probably you have to take it fully in or change the angulation.
Choosing stent size also important, no? You should not oversize.
1:1 size. Don't use a larger size stent.
And DES is recommended, no?
Yes. There have been various trials with the BMS and DES, and now DES is recommended. I mean, in an ISR. No.
Really needed.
Well, the recommendation at that time, the recommendation is if feasible, do it. That's better. We don't know how much degeneration is there at that particular point. You may throw distal emboli. If it's not feasible, no. But we thought the lesion is very discrete. We can pass it. There is adequate margin. That's why I chose it. And probably I wanted to try a distal embolic protection also.
Yeah, it is not routinely recommended. It's only class 2 indication.
It's only a class
And-
2 indication.
And they say this is the only way you can protect from distal embolization, because this is the only way. There is no other way. So if feasible, you can use that, sir.
So thank you, Kanadas, for
Thank
the
you.
next case. Next is Dr. Madhu Sridharan presenting image-guided ISR management. Let us see how he is going to manage the ISR.
Respected chairpersons, dear friends and sir. Yeah, this therapy for instant restenosis. It's a 54-year-old male. He had a new onset of excess angina class 3 for 2 months with recent worsening of symptoms. TMD was strongly positive. It's a diabetic, hypertensive dyslipidemic on irregular treatment. He had an angioplasty, but still his LDL was 230, HbA1c was 8.8. ECG and echo were normal. He had an angioplasty to LAD-D1. It's a TAP done in 2016. He had a 2.7538 Zions in LAD and 2.518 Zions in D1. So this is the angiogram. You can see there's a large diagonal and a LAD. The LAD per se, you got a bit of a disease in the mid part with tight stenosis distally, but the important part is the diagonal. You got a 90% stenosis of the diagonal with TIMI2 flow. So we had 95% ISR of D1 stent with TIMI2 flow, mild ISR of the stent in LAD with a peristent stenosis in the mid LAD. So what do? Essentially, it's ISR of D1 with some disease in LAD. Options would be either you do a 2-stent strategy, which would mean 2 layers of stents in LAD and D1 with extensive amount of metal in the coronaries, or you could do a drug-coated balloon with a DES backup for suboptimal results. Ultimately, this is to reduce the amount of metal in the coronaries, which we know it's bad. So image guidance is mandatory. So this is what we did. 7 French EBU, wire in both the branches. This is first a 2-12 Maverick into the diagonal for getting the OCT catheter. And this is followed by a OCT. I can see that the distal RVD was 3 into 2.9. So it is an underexpanded stent in the diagonal. You had a 2.5 stent in the in diagonal. And stent was underexpanded, homogeneous neointimal hyperplasia with dissection after the balloon dilatation. The ADS stenosis was 87.9%. And this is OCT from LAD. And you can see that the distal RVD was 2.7 to 2.9. There's a fibrous plaque with the MLA of 2.3. So it is still stenosed with instant restenosis. And there's again a homogeneous ISR within the LAD. So when you have any ISR, you have to prepare it well. So here we used a 3 into 10 Wolverine into D1 at 16 atmospheres. Wolverine was thought it's a new homogeneous NIH, so any cutting balloon. And OCT from D1 post Wolverine showed, you could see the cuts in the stain, and you can also see an increase in the MSA. Now that is important when you're doing ISR, because you have to have a increase in the DSA, by which you can say drug-coated balloon would be sufficient, and you probably won't need a drug-eluting stain. So you get an increase in MSA, and you can see the cuts in the post Wolverine, and this is you can see the diagonal itself had shown better after the Wolverine, and you use a 3 into 20 magic touch into the D1 at 16 atmospheres. And when you're doing a drug-coated balloon, you have to keep it dilated for at least 60 seconds. And then you had a 3 into 35 magic touch into LAD at 16 atmospheres, and did a kissing balloon with 2 drug-coated balloon at 12 atmospheres. This is a post drug-coated balloon. You can see the diagonal has expanded well with good result. And LAD, the stent per se is fine. So you had the peristent restenosis. And that part was stented with a 2.75 to 18 science, which is post-dilated with a 3 millimeter balloon at high pressures. And this is the OCT from LAD. You can see a well-expanded stent. The MSA is 4.65, expansion was 83%. And the minor dissection within the stent secondary to the drug-coated balloon, which is to be expected. But as long as the MSA is large and you don't have any flow-limiting dissections, a drug-coated balloon is reasonable. And this is the OCT from diagonal. You can see a good flow with angiographically good result in D1. And again, that's shown in the OCT. You have minor dissection within the stent, but the stent per se is well open with adequate MSA, 4.1. And this is the final result. Good flow into the LAD and the diagonal. So uncomplicated hospital course, discharged an aspirin and prasucal in well at 8 months. So irrespective of DES or DCB, lesion preparation and opening of the vessel is absolutely important when you're treating ISR. You can use either cutting or scoring balloon, ultra high pressure NC balloon, IVL, rotablator or laser. But unless the vessel is well opened, DES or DCB, whatever you do would have a high recurrence. Treatment of ISR is challenging. Imaging is essential. Here we found the reason for the stent failure, which is under expansion of the diagonal. DCB is an attractive option. Here we used a hybrid strategy at depth for both LAD and D1, and the edge peristent restenosis was treated with another DES. The advantage is limiting the amount of stent overlap and scaffolding the fibrotic plaque and distal runoff alone with a new DES so that the flow is increased. Thank you.
Dear Madhu, excellent presentation and a nice demonstration of how to do an ISR, a correct usage of imaging, and of course, as per the current recommendation, usage of depth rather than avoiding second numbers of additional stents. And lastly, using a new stent for the distal new lesion. So what was the reason for the ISR in the main stent, main vessel? In the diagonal, it was under expansion.
Yes. In the when it's 5 years post angioplasty, the guy who's not taking medicines, he can have a restenosis.
That's it's very surprising that we all talk about the correct techniques of doing angioplasty and all. But the post care, look into his LDL, 230. So there is no wonder that this gentleman came with this kind of problem. So we have to introspect and educate our
It is not done in our center. It is done somewhere
I know
else.
that. Whoever see the patient, see that patients are kept to their targets, HbA1c as well as LDL.
So total you used 2 drug-coated balloon. So initially you did sequential dilatation separately in LAD, then
first the diagonal, DCB into the diagonal.
So that time you used drug-coated balloon or only for the final kissing?
Sorry?
When you sequentially dilated, that time you used drug-coated balloon or you used drug-coated balloon only for the final kissing?
No, all the initial ones with Wolverine, with all the balloons, and once it's opened, the drug-coated, because drug-coated balloon should be used only as a final thing. You should prepare the lesions well, and only then should the DCB be used. DCB should not be as a replacement for a regular balloon. You should prepare the bed and then use a DCB.
Yeah, initially.
Thank you.
Madhu, what was the reason for that distal edge restenosis of the main stent? You have the OCT done.
It's a peristent, so it's just outside.
What was it due to? Is it a new geographical miss at the beginning? Or
it is probably damage to the trauma to the vessel. Peristent restenosis within 5 millimeters of the stent.
Yeah, it is some geographical
outside
miss. Yeah. Do you think OCT is the best imaging modality for?
For stent failure, definitely. So not IVUS.
Not stent failure, but for usage of a drug-coated balloon, because it is one of the criteria is that 30% less plaque burden after dilatation is an indication to go for usage of drug balloon. You said volume expansion is
Yes.
good, but quantitatively speaking, it is the plaque burden should be less than 30%. That's one of the criteria for going with the drug-coated balloon. So that is better appreciated by IVUS than an OCT.
But the resolution is so much better with OCT.
No, that is okay, but the plaque burden. because one of the criteria for proper usage of DES, drug balloon, is after dilatation, the plaque burden should be less than 30%. That's one of the criteria used in standard studies. That's one point used. So most of the people uses IVUS in that situation. Antonio Colombo uses IVUS.
Colombo, most of this is with OCT, sir.
For drug-coated balloon.
balloon.
Yes, he uses IVUS mostly. Second question, you have a hybrid, that is drug-coated balloon plus DES. What should be your antiplatelet regimen? Is it short or long?
Because you have a drug-eluting stent, so you should have the antiplatelet should be the same as for any death. It should not be to reduce.
So that advantage is lost
Yes.
with the hybrid.
Yeah.
Thank you.
This has been around 8 months, sir. He's fine. DCB, as like if the MSC is good, it should be good. But I don't have very long-term follow-up personally. Thank you.
Next one by Dr. Joby Thomas, laser for ISR.
Respected chairpersons, senior colleagues, and friends. So, I'll be talking about this case of this 72-year-old physician. He's a hypertensive. He's not a smoker and he doesn't have diabetes. He underwent PTC to a lady with 2 DES, one in the middle lady and another in the osteoproximal lady almost 14 years back. And he was under my follow for last 12 years. He was doing fine. And a couple of months back, he came back to me with a reason of onset hypertension lasting for almost a week or so. And he was taken for ECG, echo, and treadmill. His ECG was almost normal. His treadmill was positive, and his echo showed some hypokinesia in the LAD territory, and LV function was adequate. I don't have his previous CD, so I couldn't review exactly what was done. But this is the first angio shoot I had. And as you can see, there is tight raised nose of the LAD osteoproximal part with a plaque involving distal left main and some plaque in the sarcostia as well. So my idea was to keep the procedure simple, to go for it. I thought even though the sarcostia is involved, it's not very tight. So my idea was to debug the LAD ostium and stent from left main to LAD and do a crossover stent. And if needed, after assessing the flow and in the circumflex, go for a second stent if needed. That's the whole idea. So the approach was, it's a radial approach. 7 French EP was used to enkey the left main. And since we had this new device at our place, I thought it's okay to call it laser. And a 0.9 mm laser catheter was used, and at an energy of 40 fluents, and the 40 pulses per second was used. And as you can see, this laser catheter is moved very slowly, of almost at 0.5 to 1 mm per second. And I had to go for 4 to 5 cycles of repeated lasing, before which I had some luminal gain in the LAD ostium. This is a first shoot after this laser. As you can see, this is partially debunked, but not completely, because the laser catheter mostly ablates the tissue only in contact with the laser catheter. Maybe it gives lumen roughly the size of the laser catheter. And after this, an IVUS was done, and this is the IVUS image I had. And you can see that there's 2 stents, and there's in the proximity there's an area which is between the 2 stents. And there's a reasonable opening of the LAD ostial part. With left main was around 5 millimeter size as well. And after this serial dilatation, I used a cutting balloon of 3.5 millimeter at the left main to LAD. And after that, stenting was done. At 3.5, 48 stent was used. From the left main ostium to the second stent, that is the middle AD, partially overlapping the odd second stent. And this is the shoot I had after the stenting. As you could see, there is some pinching of the sarcostium, but the flow was fairly good. But I thought it was a good idea to dilate the sarcostium, and so a pot, then cell branch opening and report was done. And there's a shoot ahead after this opening the side branch. As you could see, there is some dissection involving the circumflex ostium with some compromise of the flow, I guess. And it was planned to stent from the sarcostia as well. So I went for a tap, and tap was done with a 2.75 15 stent in the circumflex ostium. Following which kissing balloon was done from the circ and two balloons, 2.75 balloon in circ and a 3.5 balloon in left mid to LAD. Following which boot was done using a 5 mm balloon. Having that inflation was taken in fluoro. I hadn't saved that fluoro. So you can see this balloon in the left main ostium, and this is the final shoot ahead. As you can see, there is some maybe some expansion, I presume, in the just left main. The IBS was done. Left main shot decent area of around 14.5 millimeters square in the left main. So it lies at 111 Medina lesion involving left main LAD and circumflex with ISR. And debulking was done with laser and cutting balloon. Laser is useful in these scenarios, especially in ISR and balloon non-crossable CTOs or large thrombus burden. And the laser works with photoablations involving 3 different mechanisms: the photochemical effect, the photothermal effect, and the photomechanical effects. And the photochemical effects actually breaks the chemical bonds, and photothermal effects works by producing heat and vaporizing the tissue. The photomechanical effect is due to the vapor bubble forming at the catheter tip and causing the mechanical disruption of the plaque or adenoma there. My idea was to go for a single stent start initially, but after the dissection involving circostium, I was forced to do a tap, and most often sometimes the crossover technique has to be bailed out with a tap. Thank you.
Thank you. Nicely performed case. But as per the current guidelines, this has to be a two-stent strategy to begin with, because the left main side branch, the circumflex, has more than 70% stenosis to begin with. So you should have planned a two-stent strategy upfront, as per my slides.
But it's not 70%, maybe around 50%, I guess.
Another thing, see, what was, you couldn't do a imaging initially after the
no, because it's very tight. I don't think that decision would have permitted I was catheter without laser or dilatation. Yeah, so I did after the laser. I was done after the laser.
And whatever said, if this you have to think lot of imagination. What was the real stent size in the first imaging? The previous stent.
The first stent.
Yeah.
I mean the stent which underwent ISR. I think it was pretty much opposed and expanded. I don't think this expansion was involved.
Had you tried to pre-dilate the lesion before passing the laser?
No, I haven't.
Okay.
Yeah.
Can you comment on when you would prefer lacing as opposed to rotational?
I would say this actually. This I did laser because we had it. I think this also would have been done with a cutting balloon as well. Yeah, not much difference.
So here, suppose laser was not there.
I would have gone with a small balloon initially and cutting balloon subsequently.
It's not going to make a difference.
I don't know, because I done with the laser. I don't know how things would have worked out without laser. Yeah.
So this was just the second case in our hospital 2 months ago when we started off. Fortunately, we got this particular case as a second case. We are not really sure about what should be the fluency, what should be the repetition, all those things we're not fully aware of. And again, when we looked at the data, what we understood was basically when you have a restenosis, it could be either mechanical or biological. So basically, when you do a balloon dilatation with a cutting balloon, you have 2 mechanisms. Once the stent opens up, second, you have tissue extrusion. By doing a rotablation or by doing a laser, you have a third technique wherein ablation is also going to happen. So compared to 2 techniques of opening up the restenotic segment, you have an additional atheroablation also. So then the luminal gain is going to be much better, even though long-term outcome, whatever data that is available, 25% of them, they come back with a problem in the first 1 year. Still, laser whatever data is available, it scores better than a balloon-based strategy. And it's as similar to rotablation plus balloon-based strategy.
How costly?
It's around, the catheter is around 3 lakhs, ma'am, but we could reuse it. We charge a lakh.
Lord Joby is a great case. That in a stent protrusion, a tap. If you don't to do final kissing, yeah, one technique as you mentioned. The other one is you take care of the side branch. You can pull the balloon little proximally and kiss it. Otherwise, you may crush the side branch stent.
Yeah, I think
That's one
the
thing.
port balloon was kept away from the conference, I guess. Yeah, I could see that.
Otherwise, you may
It's
crush.
not a port balloon.
That's one thing to discuss. Second one is you to do port also proximal to the tap
Yeah,
stent.
yeah.
Now, Dr. Deepak, I would like to know, you're doing a lot of laser. Suppose you have difficulty in crossing the side branch, or to wire in the side branch. If you have difficulty in crossing with the balloon, can you use a laser in that? Have you
Yes,
done
sir.
that in a case?
There are case reports and people have ended up with perforation also. So it's recommended not to do that. So when you lace the side branch ostium, you're likely to have perforation.
So what's the reason for that perforation, I think?
So
Because
basically, it's not just
because you have ostomy you have done
so the
here.
catheter size is 0.9 millimeter, and when you lace, you produce bubbles. And if you inject contrast or with blood, if you are lacing, the bubble size can be up to 3 times the catheter size. This is 0.9. It's almost a millimeter in diameter. And if you inject blood or during the lacing, you're supposed to continuously infuse saline. And inadvertently, it's more of blood or some contrast goes into that. The bubble size will be up to 3 times the catheter size. So that 1 millimeter catheter, you have a 3 millimeter bubble. That bubble implosion is what ultimately softens the tissue around. That can lead on to
So you
perforation.
need to say perforation at the ostium.
Yes, sir.
Ostium
At
with
the
side branch,
bifurcation.
side
At the
branch.
bifurcation. There are case reports that. So it's better not to do that.
Excellent case.
Thank you so much.
Thank you. So we'll wind up this session. Thank you.
Thank you all. So now we are moving on to the next session, peripheral interventions. Requesting the chairpersons, Dr. Ashraf Esram, Dr. James Thomas, Dr. Rajesh Muralidharan, and Dr. Srikala P to come forward to the dais. And please occupy your chairs.
Dr. Madhu Sridharan, requesting sir to be on the chair. We are already 20 minutes short of time. Please stick to the timing for this session so that the lunch will not get much delayed. Thank you.
So good afternoon all. So we can start the peripheral sessions, which is another important session. So for the first presentation, I call upon Dr. Shifas, and he will be talking upon SFA CTO.
Respected chairpersons, senior faculties, and my dear friends, I am going to present a case of SFA CTO. My patient is a 62-year-old hypertensive gentleman presented with a claudication, a progressive claudication of more than 3 months duration, with a non-healing ulcer of 2 months duration, and early gangrenous changes in left middle toe with a severe rest pain. And this is the CT angiogram. He was having bilateral peripheral disease. Right system is relatively okay, except for the positibial artery that was occluded, but the antitibial was having good flow. But in the left side, you can see a long segment occlusion of the SFA. And positibial and antitibial was reformed by few collaterals, and antitibial also it was occluded distally. And in the image without bone suppression, you can see that bony relations with these blood vessels. And the right common femoral bifurcation was slightly in the higher side, and in left side, the antitibial artery, it was almost parallel to that fibula. And see, these landmarks were important in this particular case. And got a right femoral axis, and this is an angiogram. You can see that SFA is totally occluded, and there is no reformation in the distal part or in the popliteal artery also. And some mild filling of collaterals we can see as in the CT scan. So a 7 French rapid sheath was introduced, and straight tip termo with a glide support. I tried to cross the lesion. Actually, initially it went easily down, and but at this particular point I felt some resistance. But sheath injection showed that I was in line with the vessel. So I did an angiogram through the glide catheter. So this was a result. Initially, I thought this is a perforation and some extravasation, but later the dye cleared and some filling of popliteal vein seen. So I tried with one more wire, but the result was same. So I changed the strategy, and with the bony landmarks as well as with the help of ultrasound, I got an access to the distal antitibial artery with a 5 French sheath. And this is the angiogram from the retrograde sheath. You can see total occlusion of ATA and PTA also occluded, but filling with the collateral. And again, I tried to close the lesion with the straight termo and a glide catheter. And I kept that antegrade glide catheter in the proximal cap of the SFA occlusion. So this retrograde termo wire entered into the glide catheter, and I took it through the femoral sheath. And with the support, the antegrade glide catheter advanced over the retrograde termo wire into the termo, into the ATA. So confirmed with the injection, and I am in the lumen. So dilated with a 4 into 100 millimeter balloon. And this was the result after balloon dilatation. The retrograde injection showed a very nice result, but the antegrade, the flow was not that great. Some dissection or something was there, but I was in a dilemma whether to stent this or not, because it's a long segment stenosis, and that too across a major joint. So, but at the same time, I was reluctant to leave the patient with this much symptoms. So finally stented with the two overlapping supera, 4.5 into 150 millimeter and 5.5 into 120 millimeter supera, and post-dilated with a 16 to 100 millimeter balloon. And this is the injection after stenting. There was occlusion of the ostium of positible artery that was closed with a WIN 40 wire and dilated with a 3.5 into 40 millimeter balloon. And then the result was good. The retrograde sheath removed after inflating a 2.75 into 50 millimeter balloon distally by using the balloon diaphragm technique. And this is a final angiogram. And after 6 months follow-up, he is asymptomatic. The wound healed nicely. Take-home messages. Retrograde PTA is useful method when antegrade technique fails in peripheral angioplasty. Understanding the infrapopliteal vessel anatomy in CT angiogram is important in retrograde access. Ultrasound guided or fluoro guided access are possible. Understanding the artery to bone relation in CT is helpful in obtaining the retrograde access. Thank you.
I think it's a great innovation on table. You could not cross from above. You punctured the ATA and great idea to use balloon tamponade also to close the puncture. What must have happened initially?
That I don't know. Maybe the wire was went through some collaterals into collaterals. That's initially I thought it is I perforated and it was extravasation, but
we could not see any perforation.
No. Actually, I checked with the ultrasound also. There was no perforation, and that dye actually immediately cleared into the popliteal vein. So probably through some collaterals, it went into some channels. I don't know.
Can I add on something there? See, it was you're partly through the anterogradely you had gone subendimally.
Yes.
That is the only problem there.
Yeah.
Actually, you had crossed into the lumen, and you had been in the lumen actually. What you did wrong was you injected proximally.
No. I injected in the glide catheter. That
exactly.
That showed that filling of popliteal vein. It should not be there, no, sir.
Popliteal vein, I'm not sure.
Popliteal vein
Yeah.
filling.
No, but that in that case, it should have been there even after the procedure. No, that perforation.
That's second crossing was from retrograde. It was through the different channel.
My this thing intuition there is that you had gone subendimally there, proximally.
Yeah.
Now your catheter is in the subintimal space.
Yes.
Your wire is in the true lumen distally.
No. Wire was not in the true lumen, because in that case that popliteal vein should not fill with the injection.
And what is this rabi sheath?
It is a long sheath only.
Yeah. Ashish sir.
My only contention is, see, you have used an 035 wire from the tibial.
Yes.
Right?
Yes.
And we have punctured the distal anterior tibial because the pedal vessels are not, they are probably all both the pedal vessels are diseased.
Yes.
So I'm a little concerned about using 035 because they are 2 or 2.5 at the most 3 millimeter vessels.
Yes.
As we don't use it in the coronaries, here also it'd be better to use 014 wires because see the angle terumo, it actually, if you want to actually turn it around, it requires larger space.
Yes, sir.
So I would probably suggest an 014 wire, and the advantage is you don't even need a sheath. Your idea is only to cross and you can finish the procedure from above.
And in this case, that actually the ATA was occluded at that particular point.
Exactly. So all the more reasons is that it should not go into spasm. So 035 wires induce a lot of spasm in
Yes.
tibials.
And the distal flow was maintained through the PTA. That's why I selected that entity.
Sure.
Okay, thank you, Srifas.
Thank you.
Next, let us call upon Dr. Anoop.
First of all, I would like to thank Dr. Pratap and Dr. Ashish for giving me an opportunity to showcase my case. Now, this is a 56-year-old male who presented with left arm pain, muscle weakness of the left arm of long duration. It was almost of 2 years duration. He was advised finger amputation from another center due to digital necrosis. When I examined him, I found that the radial pulse was weak, the brachial pulse was weak, and this was his hand at the time when we saw it. I did first an color Doppler of the left arm to find that there was no flow in the left arm. Then we did a CT angiogram of the arch and the vessels, and we found that there is a total occlusion of the left subclavian. I took a JR4 guide and saw that there is a total occlusion of the left subclavian from its origin. With the Filder XTA wire, I tried to cross the occlusion using with the 4.5 into 8 millimeter NC balloon support, but every time the catheter was backing out. So I used an 8F shuttle sheath, and through it, again, I used Conquest Pro. And with Conquest Pro support, I was to some extent successful in passing the wire across. I dilated the proximal part with a 4.5 into 8 mm balloon. Then I found that distally there is another CTO segment in the distal part, which even the Conquest Pro was not crossing through. So I changed the wire to a Teramo wire. I crossed the lesion with a Teramo wire, and after taking a 5 into 40 millimeter peripheral balloon, I was not able to cross the bend. So again, I rewired with Filder FC this time and took a 4.5 into 8 millimeter coronary balloon, and I opened up the CTO segment distally, and then passed a 5 into 40 millimeter peripheral balloon through the Teramo wire, which was rewired again. After that, flow was established in the artery, following which I placed an 8 into 57 millimeter balloon expandable peripheral stent from the proximal left subclavian. Post-dilated with an 8 into 40 millimeter post-dilatation balloon, and this was the final result. You can see the flow right up to the tip of the fingers. There. 6 weeks, I think, 6 weeks later, this was the result. I think that digital necrosis disappeared. And then after that, I tried to test him why he had this occlusion. And to my surprise, I found that his hemoglobin was around 21, hematocrit was around 63. So we tried to investigate him for polycythemia. So I thought he had secondary polycythemia. We did an ultrasound abdomen to find that he had a renal mass. CT abdomen showed that there was a renal cell carcinoma, T1N0M0. Biopsy showed a clear cell carcinoma of the kidney. He was sent for surgery, and total radical nephrectomy was done in this patient, following which he improved. But later, I have not done the remaining analysis. He came to me actually 6 months later with a chronic mesenteric ischemia and abdomen and an accelerated hypertension. I found that he had a superior mesenteric artery stenosis proximal, which I have already stented. I think I'll show you in the next conference, that part. And the left renal artery was also stented. Then I revived him, I re-evaluated him again. I found that his hemoglobin again was around 18 and hematocrit was again 60. So then we thought that time I thought we should send for a JAK2 mutation, and we sent for JAK2 mutation, found that it's actually a case of primary polycythemia. Probably the renal cell carcinoma was not the reason for the polycythemia. So now he's doing well. We even did a PET scan to see if there is any metastasis. There was no FDG uptake. He's back to his work and it's almost 1.5 years. Thank you.
Thank you, Anup, and well done and well worked upon as well. I've just been curious about this. Last case, we saw a balloon self-expanding stent being post-dilated. Now you have used...
No. It's a balloon expandable
stent.
stent. Yeah.
In your case, it's a balloon expandable stent post-dilated.
Yeah.
So is there a difference when you use in a post-dilatation with regards to a balloon expandable stent and a self-expanding stent in a peripheral case?
So in a self-expandable stent, if there is a residue that is more than 50%, you can, of course, balloon expand that part. In a balloon expandable stent, of course, you can get the caliber problem. Yeah, he's a smoker, sir. He's not diabetic.
There is answering the question of Rajesh. There is a difference because the self-expanding is size set. See, if you're using a balloon expandable for a 6 millimeter vessel, you use a 6 itself.
Yes.
For a self-expanding, a 6 millimeter stent is for a 4.5 to 5.5 millimeter vessel. So you can't take it up to 6. That is the difference.
I didn't get it, sir.
If for a 6 millimeter vessel, you use a 6 millimeter balloon expandable stent.
Okay.
For a same 6 millimeter vessel, you would probably require a 7 millimeter self-expanding stent because it goes from 5.5 to 6.5.
Okay.
So if you have taken a 6, then obviously you can't post-dilate it to 6.
Okay.
Great case, Anup. Many often in these ostial subclavian occlusions or juxta-ostial, we often not get the support to cross coming from below. So it will be useful if we can put a brachial.
Yeah, you can. In this case, it passed, so I didn't have to go for the this thing, retrograde injection.
Anup, great case. But how sure you were in first the dilating with the balloon when you partially entered the? You are not sure whether you
No. So only when I crossed the edge, that is the acute bend. After I took the acute bend only, I dilated because we have already seen that the proximal subclavian is very large.
Okay,
So,
but how can you be absolutely sure that you are in the
that's
true
why
domain?
I gave a small balloon dilatation and I saw the flow coming. Then I was sure that we were inside. It was not in a full pressure.
And this subclavian occlusion, would you use a coronary hardware or would you use Termo with a...
I really didn't want to go with the Termo initially because I had a bad incident before. I had dissected up to the part, passing the Termo through. So I thought in this case, first we'll cross the CTO segment C and then pass the Termo if required. So it is the second segment which I could not get through with the coronary wire. So I went with the Termo after that. Only thing is I had to change the hardware. I kept on changing the hardwares in between.
But in peripheral CTOs, I thought, you get more pushability with the Termo and the diagnostic guide.
Yeah, that's...
Great. Now, can you have the next case?
Thank you.
Thanks, Anup.
Next case, we have Dr. Srigala, recurrent ISR CTO of left SFA in critical ischemia under OCT guidance.
Respected chairpersons and senior colleagues and my dear friends, at the outset, I would like to thank the organizers for giving opportunity to present this case before you. So this case is a story of a patient who presented with recurrent instant restenosis of left superficial femoral artery. So my patient is a 73-year-old male with diabetes and hypertension for 25 years and old coronary heart disease, anterior wall and STEMI, for which he underwent proximal LAD angioplasty 8 years back. And he also had a peripheral occlusive vascular disease around 5 years back, for which he underwent left SFA angioplasty, that is proximal 6x40 and mid to distal SFA was stented with a 6x120 millimeter stents. And I reviewed the angiogram of this patient. It was not done in an overlapping manner. So there was some normal, the so-called normal segment in between the two stents. And this patient had severe rest claudication 1 month post-procedure, for which a repeat balloon angioplasty was done in the same center. And he was on regular medications and he had recurrence of claudication symptoms 2 years after the index procedure, for which he underwent a repeat peripheral angiogram, which revealed a diffuse instant restenosis of the distal the long stent. And he underwent angioplasty with a 5x100 drug-coated balloon in the second center. So he presented to me with recurrence of symptoms with severe rest claudication for 2 months. So again, his clinically he had absent popliteal pulses and he had evidence of critical limb ischemia. So I took him for a peripheral angiogram. You can see again a long segment instant restenosis, chronic total occlusion of the distal stent with poor infrapopliteal flow. So we planned the procedure with OCT guidance to see what is the cause of his recurrent instant restenosis, because initially it was done in a good center with a drug-coated balloon. So we opted for an antegrade puncture. The CTO segment was crossed with a hard end of thermo wire with a guiding catheter, RCA guide catheter, and with a 2 millimeter balloon. After the 2 millimeter balloon dilatation, the 3 runs of OCT was taken because as you know, the OCT will cover 70 millimeters. So I have to take 3 runs of OCT from the proximal popliteal to the proximal SFA. So the initial OCT itself, you can see, shows a significant instant restenosis. The initial segment was measured was 60 millimeter. So showed a significant neo-intimal hyperplasia with 80% atherosclerosis with areas of spotty calcification. The entire segment was studied and it was 80% stenosis in the initial run. Now the second OCT run was again taken from the that is the mid part of the distal stent to the proximal part, and in this it was demonstrated that there was a stent edge dissection in the distal part of the stent. So the distal part, I have told, it was a 6x120 millimeter stent. Actually, that the proximal part of the distal stent, there was a flow limiting dissection which was not recognized in the initial angiogram. So that might be the reason for his stent restenosis, and there was, as you can see, a lot of thrombus, a lot of areas of dissection were there in the OCT. And the third OCT run also showed the proximal 6x40 millimeter stent also showed an area of restenosis. So my plan was to dilate the entire segment with a 5x40 millimeter, 5x60 millimeter peripheral balloon, and the entire segment was stented with 2 stents, 6x120 and 6x200 millimeter stents with in an overlapping manner, and the final angiogram revealed a good dilatation and a good flow in the infrapopliteal vessels, and he was relieved of claudication symptoms. So this case highlights the usefulness of OCT in peripheral ISR CTO. Actually, I think this was the first case done from our center for peripheral OCT. And the cause of repeated ISR was identified as the second stent edge dissection, as I have demonstrated earlier. And this was not identified in the first and second procedures where the drug-coated balloons were used. And he was discharged on dual antiplatelets, and the peripheral pulses appeared post-procedure. So thank you for the patient listening.
Shikil, a couple of things here. One, how about the procedure? How did you do the OCT? Was it a...
It was a regular OCT catheter,
was it
which...
with the pressure injector, or was it...
It was with the pressure injector.
Now,
it was with the pressure injector,
now,
because the size of the... You can see the size of the SFA is around 6 millimeter.
Now, did you dilate the stent before you...
Yeah, I dilated because it was a CTO segment. So I dilated initially with a 2 millimeter balloon, the entire segment. So that might be one of the reasons for this extensive dissections which you are seeing in the OCT.
When you have the dissection there, how can you say that the edge dissection was the reason for the instant restenosis?
Edge dissection, the OCT, it is not clear in this picture, but the OCT...
No, but the dissection could have been secondary to the balloon.
The angiogram also showed. The first
when you have any dissection, the dissection would heal in a couple of weeks. So that would not be the one that even if there was a dissection there, that would have healed by the time you do it the procedure.
No, the patient actually had an subacute stent thrombosis after the first procedure. So I reviewed all the angiograms, all the peripheral angiograms, and the first index procedure itself, the second stent was placed in the dissected segment. So when he presented with subacute stent thrombosis, just a balloon dilatation and thrombus aspiration was done, and nothing was done for that deceased segment. So again, he had the second occlusion in the same segment in the distal, because the proximal stent is okay. Proximal stented segment is okay. Only the distal part of the stent is getting occluded.
Now, my thing is, even if dissection was the cause for the stent thrombosis, you still cannot make it in an OCT done now.
Yeah, that is true. That is true. But I think that might be the reason, because in the CTO segment, you cannot pass the OCT catheter without pre-dilatation.
Absolutely, yeah.
No, sir, because after the extensive, because I have done the entire segment, there was lot of areas of, because you can see there is critical areas of neoatherosclerosis with hyperplasia. Almost 80% of the distal stent was occluded, and there was critically, flow was also reduced. So after pre-dilatation, I decided to stent the entire segment.
How do you size the second stent? How did you size the second stent?
Actually, it was initially itself, it was 6. So I also used a 6 millimeter, a 6 size. But the length was, I did in an overlapping manner.
Can I ask? The usual teaching is that in large vessel, the OCT is not very useful. Like that is why we don't use it in the.
That
so
is,
how useful is in the peripheral vessels of 6 millimeter or so?
peripheral OCTs, actually before this case I discussed, because peripheral OCTs usually is not being routinely done in India. I think I have discussed with this with one or two centers in Delhi, where they usually do in Apollo and in Indraprastha Apollo hospitals. I have discussed with the head of department, and then only I did the case.
Same catheter, the Dragonfly.
Same catheter, same OCT catheter, which we use for coronary, but you have to use a pressure injector to get a good clearance of the blood.
Okay.
Thanks, Shikila.
Thank you.
Next, we have James.
Good evening. Good evening, respected teachers, seniors, and dear friends. So, critical limb ischemia interventions. Basically, I'll show a few cases of below knee interventions. Why talk about below knee interventions? Because the first case, this is a 73-year-old lady, diabetic. She underwent a SFA, left SFA and popliteal angioplasty in April 2023. It was done in another center by an interventional radiologist. And at that point of time, they had not tackled the below knee vessels. They just dilated the SFA and popliteal artery and said that since it is distal, so they can't do much about that. The problem was that even after 3 months of doing the procedure, her ulcer was not improving. And she was in severe rest pain. So we took her up for an angiogram, and we can see that her entire SFA and the popliteal artery which they had dilated had restenoed significantly. So we dilated first with a 3 mm and 4 mm balloon after crossing with a 035 thermo guide wire. It was that part was easy. The main problem was that the outflow was very bad. So here you can see that occluded PTA and peroneal artery, and you can see the ATA. There's a proximal short segment occlusion followed by distal diffuse disease. Actually, it was a relatively easy case. So we could cross the lesion with a command guide wire and dilated dilated the anterior tibial artery with a 2.5 into 100 mm balloon, and we had a reasonable result. And yesterday I got her latest picture of her limb, and it is showing reasonably good healing. Basically, this was not a very difficult case. I basically presented to convey the fact that whenever we are doing an SFA interventions in critical limb ischemia, please don't stop by doing an SFA intervention. Please take care of the below knee vessels also, because otherwise it can again get reoccluded. So this is another case, the 71-year-old diabetic lady with a right big toe gangrene and severe rest pain. Here again we can see distal popliteal artery total occlusion taken in two angles. And here the problem was we didn't know which way the vessel was going. It's an ambiguous proximal cap, whether it is occluded here or it is occluded there. So we first tried to pass a command guide wire with microcatheter support. We probed at both the points, but we could not pass the wire beyond that point. But ultimately, we could cross the lesion by once a loop happened in the wire, and we could cross the lesion with a loop. Many often these type of loops actually help in crossing especially below knee lesions. Here you can see the loop, and the vessel and the wire is now inside the peroneal artery. You can see that the wire is now inside the peroneal artery. The lesion was dilated with a 3 mm balloon. You can see the peroneal artery getting opened. Now I thought I will attempt the ATA also, and we could pass the wire down till the dorsalis pedis, dilated the ATA, and this is the final result we had. We had an open ATA and an open peroneal artery. And lastly, this is an 84-year-old man with severe rest pain and gangrene of second and third toes. Again, significant, you can see significant SFA disease coming from the other side. You can see significant SFA disease in the distal part. It was dilated. We had a reasonable result. I usually don't stent the SFAs unless I really need to. And below knee, again, here again the problem, we got 3 vessel long segment total occlusions of ATA and the tibioperoneal trunk. Again, we could cross the ATA by using the same command guide wire. Again, you can see a small loop at the distal in the terminal part of the wire. You can see that. Again, this loop actually helps in negotiating these type of long occlusions. Now the wire is in the dorsalis pedis, dilated, and we had a reasonable result. This is the pre-angioplasty image, and this is the post-angioplasty image. The flow is reasonably good till the dorsalis pedis, and we got a reasonable plantar arch also. So the message is that my messages I wanted to convey was never stop in CLI interventions, never stop after tackling SFA alone. Always take care of the below knee vessels. Always try to ensure at least one patent tibial vessels, which preferably crosses the angle, and dedicated peripheral hydrophilic guide wires like this command guide wires and microcatheters are priceless in BTK interventions. And sometimes these type of small loops can save your day and save you a lot of time. And perseverance often pays in BTK interventions. Thank you.
Excellent, James. A couple of things. One, when you're doing these ones, if you're doing an SFA, for example, and you find it's occluded and you open it and find infrapopliteal disease, do you tackle that at the same time or in another setting?
Same time.
Same setting.
Same time. I try to open the SFA, don't stent it, then take a guide catheter down into the popliteal artery, take an angiogram, and then finish it off like a usual coronary procedure.
But I was told that, that when you're doing the first SFA, if you put a stent and you find disease down, you do it in another setting. Not necessarily.
I think it is always better to do it in the index procedure, because if you don't do it, you are having a stent or a dilatation without a good outflow. Then you can even...
Just one more. Yeah. And when you're doing all these things, do you do antegrade puncture or retrograde?
Antegrade means antegrade femoral. Yeah, in 1 or 2 cases, it's always better to do an antegrade puncture, because you get better crossability for the wires and better pushability for all your devices. But in some settings, you have some proximal disease in the SFA or a very obese patients where you find it difficult to do the antegrade puncture, you come from the other side. But for below knee, it's always better to go antegrade.
James, wonderful presentation and wonderful message. Actually, this is one message which we like to carry on with SFA as well as other interventions, peripheral interventions. Because you need to have one linear flow from SFA into the pedal arch or plantar arch. The plantar arch should be complete.
Yes.
One vessel is good enough. You don't have to go for both the vessels.
Yes.
One vessel which goes into for your question, it should be done in the same. Otherwise, what will happen is that if there is no outflow, the whatever work you've done with the SFA is going to close down in few days or few months.
Yes. That is a concept which was there, but there is the healing is very poor if you don't tackle the belonia vessels. And also the index procedure which you have done, whether it is stenting or dilatation, there is more chance the vessel gets occluded in the coming time. People actually stent, but personally I have only stented only. Usually we try to avoid stents in BTK interventions.
When we are doing SFA and infrapopliteal in the same sessions, in the same sitting, I think the only difference, what I feel is, I want your opinion also, for the SFA, regular termo would be a better guide to negotiate. But when it becomes infrapopliteal, you have to go to specific, specific peripheral wires, hard wires. And the catheter always preferred for SFA as well as is the word catheter.
Glide catheter.
Glide catheter, word glide catheter.
For SFA.
For both.
For below-knee interventions, you don't need the glide. We have actually dedicated peripheral microcatheters. Now what I use usually is the Rubicon from Boston. I have not shown that. Okay. This is I think from Cook, which I showed. The Boston people has got a very good microcatheter, which is the Rubicon, which is we got O14 also and O18 also.
Thank you.
Thank you, Dr. James, for the wonderful presentation. And due to lack of time, we will go to the next presenter. I now call upon Dr. Girish, and he will be dealing with an unusual presentation of left subclavian artery stenosis. Over to you, Dr. Girish.
Respected chairpersons, seniors, and my dear friends. First of all, let me thank Icck sir and the Icck team for giving me this opportunity. So my patient is a 60-year-old gentleman, hypertensive and diabetic, underwent PCA to LAD in 2008. Currently, he got admitted with a diagnosis of sensory TA in neurology ward. And his MRI, he had multiple similar episodes in the past. His MRI brain and MRI angiogram was normal. And cardiology consultation was sought for looking for any evidence of cardioembolic source, and he had fluctuant blood pressure also. So clinically, he had a significant difference in the systolic blood pressure in the both upper limbs. The right upper limb is 190 and left upper limb it was 130. So we thought of a stenosis in some lesion in the left subclavian artery, and we proceeded with a CT angiogram of the aorta and arch vessels. The CT angiogram showed a bovine aortic arch with a shelf-like subclavian artery stenosis causing more than 90% luminal narrowing. The lesion was shelf-like lesion with no circumferential extension. There was no vessel thickening or involvement, no significant plaques or calcium as we seen in atherosclerosis or Takayasus. So we proceeded with the subclavian angioplasty. The hardware used, I will come later on. So we took two axes, left radial and right femoral. So the plan is to cross antegradely and stent from the right femoral side and retrograde approach from the left radial side only if it fails. So initially there was a significant blood pressure difference between the right femoral and left radial, almost 40. And the pigtail shot close to the left subclavian artery showing a significant proximal stenosis. So we did a selective injection of the innominate artery to look for vertebral steal. There was a significant reversal of flow in the vertebral artery and the distal subclavian artery suggestive of a vertebral steal. So this gives the functional significance of the left subclavian artery stenosis. So we proceeded with subclavian artery stenting. We took we upgraded the 6F sheath to the 7F destination sheath, and it was placed in the placed close to the this subclavian artery origin. A glide cath with a 5F glide cath with a 035 termo wire. We crossed the lesion antegradely itself. Then we took the glide cath over the termo wire, exchanged it for a Amblite's 035 stiff wire, and we took the destination sheath up to the ostium of the subclavian artery. Then we proceeded with the stenting, and we took it's Herculean stent, that is own 4 compatible stent. So we exchanged the Amblite's wire with an own 4 wire. So we took a 715 and we deployed at 11 nominal pressure. So well exposed stent. The destination sheath injection shows a well expanded stent, TME3 flow to the distal vasculature, good flowing vertebral also. Finally, we took one more selective injection of the innominate artery that didn't show any reversal of flow in the vertebral. The vertebral steel is totally gone. So the post-procedure, there was no significant gradient also. The patient abruptly got rid of these symptoms, and he is in the regular follow-up for the past 9 months. He never had any such symptoms afterwards. So the take-home points, bovine aortic arch is a common anatomical variant, and always there is an importance of a detailed history and physical examination many times to clinch the diagnosis, and the importance of the forelimb BP assessment. Many times the subclavian stenosis is diagnosed on base of this forelimb BP assessment itself. And presence of vertebral steel is an indicator of the severity of proximal subclavian artery stenosis, and resolution of the steel is an indicator of procedural success. And balloon expandable stent is the choice for the ostial and proximal subclavian artery lesions because of its precise apposition. Thank you.
You could get away with a very short stent.
Yes, 715.
So was there any difficulty in placing?
No, there's not much of difficulty.
Okay.
Yeah.
What was the cause for this isolated subclavian artery stenosis?
Yeah, that's the thing. That truly just I didn't say that, but the CT angiogram report, it was just like a shelf-like structure. There was no circumferential extension. There was no plaque, no much of calcium also. So it's unlikely atherosclerotic or Takayasu. So the explanation is it can be a dissection flap. So this CT angiogram report was like that, more of a dissection, and it recanalized, and the direction is towards the vertebral artery itself. So only we first attempted for the antegrade cross of the termo itself.
Was there any history of trauma? No.
No, nothing like that. Yeah, he's diabetic hypertensive, and he underwent an angioplasty to the LAD also in 2008. So he was on dual antiplatelet statins and all. Pardon? No, we took, no. It was right, I don't know, 2008. So it was done earlier. So, but that was quite unlikely. And left radial for the LAD angioplasty in 2008 is quite unlikely.
Girish, the left radial catheter that you put, was it just, because it's just an 80% stenosis, you probably wouldn't have expected any problems with the femoral. Was it just to document the pressures or?
Yeah, document the pressure, that's one thing. The another thing is because I felt that by the coronary where we could have crossed the lesion easily to the left radial artery. But from this one, it's a proximal stenosis. So through the glide cath, the termo to cross the lesion may not be easy. So suppose in that case, so I thought that first I will put the left radial artery access also.
Girish,
Yes,
excellently done case, and it's so reassuring to see that all your images are DSA images.
Yes.
One concern, Herculean is basically a renal stent.
Yes,
715 is a renal stent,
yeah.
which is not ideal for it does not have the same tensile strength as for another peripheral stent.
Omnilink.
Yeah, or else you could have actually used an Express from Boston, which is actually a very sturdy stent. This is not a very sturdy stent.
Okay. Actually, we initially planned for that omni-link stent, that O35 compatible thing only. But actually the size was not there. Solely we changed for the 1-4 type. That's the thing.
Thank you, Dr. Girish, for the
Thank
wonderful
you.
presentation. So for the last presentation, I call Dr. Pradeep Sagar for his catheter management in pulmonary embolism.
Respected teachers, seniors, and my dear friends. It's not a big case, but decision making was a little bit difficult. I'm presenting a case of 65-year-old male who was diabetic hypertensive dyslipidemic, had surgery done 3 months back for a benign mass in the right leg. Regular physiotherapy was being done. He had a foot drop also. Sudden onset of breathlessness in few hours. He came to the emergency department with tachypnea, tachycardia, hypotension, saturation fall, had S1Q3 T3 pattern in ECG, and echo was showing significant RARV dilatation with severe TR and PH. Immediately CT pulmonary angiogram was taken. There was a large massive thrombus in the left pulmonary artery and with actually perfusion defect also. This CT image is showing significant perfusion defect in the left side and a moderate perfusion defect in the right side. So with that, we took the patient immediately to the ICU, gave intravenous tenteplase via internal jugular vein. Our emergency department team would definitely put a IJV immediately. So we had given a 20 mg of tenteplase intravenously via IJV. And then following that, since the patient suddenly collapsed, we took the patient to cath lab to give rest of the tenteplase. Initially, right femoral vein was punctured, and then we had exchanged the JR catheter with a pigtail catheter, and then we planned to give intra-arterial thrombolysis. 10 mg was given immediately. Then we tried to pulverize the thrombus, but the thrombus obstruction was still persistent, but the perfusion little bit improved. Slowly, perfusion improved, but the thrombus obstruction didn't relieve. So we tried to aspirate it, then also there was no result at all. Then rest of the 10 milligram of tenteplase was given 0.5 mg per hour for about 10 to 12 hours so that the thrombus size may reduce. Immediately post-lysis, we saw that there was some amount of improvement in the perfusion, but the thrombus the obstruction didn't go. So after about 10 to 12, 14 hours, we took a check angiogram, and this was the result that thrombus was totally lost and the obstruction was totally lost, but perfusion was also improved. So this was the immediate post-lysis picture, and after 12 hours, this was the picture. So CT also was repeated, and CT was showing there was an improvement in the flow as well as obstruction was relieved and also perfusion was present. So take-home message: an acute massive high-risk pulmonary embolism is always fatal. So managing a pulmonary embolism is still a dilemma with serious adverse events. Early and prompt management of such cases can be life-saving. A catheter-direct treatment for a thrombus is life-saving with least complications. And intravenous, that is lysis via internal jugular, can be a novel method with least facilities. And ultrasound facilitated catheter-directed thrombolysis with a short duration and minimal dose is the best method of treatment that is coming up. Thank you. Sir, that was actually in that accident, basically patient was in hypotension. So immediately in the emergency department, they used to put the internal jugular vein puncture and then give the IV infusion. So initially itself, we thought that we will give it intravenous through the internal jugular itself.
Even in your summary, you have said IJV thrombus. Is that recommended, or is it?
It's rarely being done, sir. It's rarely being. It's not recommended as such.
Infusion was given by pigtail in the.
Yes.
The pigtail was.
Yeah.
No aspiration was tried.
Aspiration was tried, sir, but nothing came.
Nothing came out. With what catheter was used for aspiration?
No. With pigtail itself, we tried manually. Penumbra, nothing was used. Penumbra was not used.
Guide catheter, nothing was used.
No, at that situation, it was not used.
Penumbra really works better.
Penumbra really works.
Really works,
Definitely.
At
that time, we didn't have penumbra, but
it's available. We have used it for some cases. It's
definitely
really good. Actually.
Penumbra is good, sir.
And for aspiration, I think for peripheral cases, you can use a RCA guide catheter because pigtail, you have a coil, so the thrombus won't come much easily.
Actually, I tried with a JR guide catheter and tried to aspirate it, but even it was failure.
What was the dose used? Like you completely thrombolized?
I totally used about 40 mg. 40 mg was
Of 10
used.
at
The
price?
20 mg initially, then 10 mg, later 10 mg as an infusion, a 0.5 mg per. Initially, 0.1 mg was started. Then slowly, hourly, we uptitrated the dose so that the bleeding risk is avoided. That's it.
So it was an infusion or a bolus followed by an infusion?
Later infusion. Initially bolus.
20 milligram. Half the dose as bolus and followed by an infusion.
Infusion. Yes.
Over 1 hour. Over.
That is about 10 hours, 10 to 12 hours it was.
And
hourly 0.5 mg.
As there was a pigtail in the pulmonary artery, did
Yes.
you try for a mechanical thrombolysis?
I tried for pulverization, but that also was, it is very hard thrombus actually.
But that is a regular pigtail, right? You are using? Not
Yeah, a regular pigtail, not the other one.
When you use JR catheter for aspiration, why it fails is the thrombus gets stuck inside the catheter. So with penumbra, what happens is they have a separator. It's nothing but like a rota bar, it just pushes. So you can use the same thing. Our conventional wire itself, you use a manifold and just flex, put it in a knuckle. And then you can actually pass this wire through a JR itself so that this stuck thrombus goes off and you'll be able to suck better.
Okay, sir.
What was the first dose of IV thrombolysis?
20 mg was given, sir. Initially, 20 mg was given.
What was the weight of the patient?
Weight was 75 kg.
20 is too low for IV thrombolysis, for pulmonary embolism.
But initially itself, the patient was in cardiogenic shock, and so we thought about that. After CT itself, there was a large thrombus.
I know, but that's all the more reason that you have to give full dose of thrombolysis.
Yes.
IV. Huh? What does it? No, the first dose of IV thrombolysis in pulmonary embolism, I think he has given only 20 milligram. I think it should be 0.5 milligram per kilogram according to body weight.
But the patient was hemodynamically unstable, so immediately we thought that we will take him to the cath lab and then try to remove the thrombus.
Okay. The initial plan was catheter based.
Yes.
That's the initial plan.
Sir.
Okay.
So shall we close the session, sir?
Yes, perfect. Thank you, everyone. We had a wonderful session with excellent talks and we learned a lot. I mean, I learned a lot. Thank you.